Good morning, everybody. Happy Saturday. Good morning to those on the West Coast. It's super early for you. We'll just give it a second, let everybody make their way in before we get started. Happy Saturday, Dr. Fanelli. How are you?
I am well. I am very well. North Carolina is having a lot of nice weather today. So yesterday was 80. Today is going to be 70. So earlier this week was 22.
Well, this is our cozy pharma weekend, so hopefully everyone is nice and cozy at home. Here in Connecticut, it's about 40 degrees, so it is a perfect day to spend the weekend getting some CE. But speaking of CE, let's get started since everyone is rolling in. I want to welcome everybody to Wu University's Oral Pharma Weekend. This is something that has been super requested by so many attendees, and it's a great way to start the year, get some of your credits early, and spend the weekend with WooU and some amazing presenters. And we're really, really excited to be here. So it's my great pleasure to introduce Dr. James Fanelli, our first presentation of the morning. And I'm Dr. Jennifer Stewart. It is my great, great pleasure to introduce Dr. Fanelli, who's originally from suburban Philly and attended the Pennsylvania College of Optometry, where he graduated in 1985. He's been in private practice since that time in coastal North Carolina, where I'm a little jealous that it's 80 degrees, or 70, I'd still take that, specializing in ocular disease management. He's lectured around the country at state and national meetings on a wide variety of topics, dealing primarily with advanced diagnostic and therapeutic modalities. He's developed a course for certifying ODs in the use of injections in primary eye care that has been used by several states and which was required for licensure renewal of North Carolina optometrists. He's a contributing editor for Review of Optometry and the author of the bi-monthly Glaucoma Grand Rounds column. He's a past president of the North Carolina State Board of Examiners in Optometry and a past trustee of the North Carolina State Optometric Society, where he served as continuing education chairman. He serves as chairman of the iSki Optometric Conference and the CE in Italy Conference. He's an adjunct faculty member of the Pennsylvania College of Optometry. It gives me great pleasure to welcome you. We can't wait to learn from you. And I'm going to turn it over to you.
Thank you, Jen, for the very kind intro. Let's go ahead and get started because we've got a lot of information to cover today. So obviously the topic for this entire weekend is oral medications. And I'm going to be starting off with a couple of 2-hour course on some general use of oral medications. These are my disclosures. None of those disclosures affect the content of this presentation, and all disclosures have been, conflicts have been mitigated. When I do my courses, I try to keep it real and keep it clinically relevant. So my goal at the end of this is for you to give you 1 or 2 things that you might be able to take home to start using in clinic when you get back to the office on Monday morning. A couple of preemptive comments, though. When we're talking about oral medications, there are many ways to correctly use oral medications. There's not one right way, except for a couple of instances. But there are only a few ways to incorrectly use them. In other words, no matter what you choose, it's going to be the right option. So what you're going to hear are things that have worked well for me. And perhaps in that, and we're going to take a meandering tour through a variety of anterior segment problems, perhaps in that you're going to pick up those 1 or 2 comments. So keep in mind, this is not written in stone. There's a variety of ways to approach these conditions and these situations. And I'm just kind of giving you an overview. So given the fact that most of the indications where I'm writing prescriptions for oral medications are anterior segment complications, I'm going to confine my comments for this lecture mostly to anterior segment. So here's your classic scenario, and probably one of the more common indications are infections of the eyelid primarily. And this particular situation, and it's again, just a representative case of an individual with, just a chronic blepharitis. The individual specifics related to this history are not important, but keep in mind that individuals with chronic blepharitis have a variety of chronic waxing and waning symptoms, including hordeola, chalasia. There's a variety of ways to treat this. Most commonly, on the first 1 or 2 episodes, we're treating this with topical medications. But the question really comes down to what happens when you've exhausted several topical therapies and you need to move on to plan B. What is that plan B? How do you approach that plan B? And invariably, that plan B, according to this topic today, is going to involve oral medication. So these individuals will present with a variety of degrees, levels of blepharitis. It could be ulcerative blepharitis. It could be seborrheic blepharitis. Needless to say, when we're looking at these eyes under the slit lamp, usually acuity is pretty good. Sometimes if the cornea becomes involved with some SPK, the acuity will tend to decrease somewhat, but the lid margins have that very characteristic appearance. You get some staining to the inferior third of the cornea. Everything else is really somewhat non-contributory. So how are you going to deal with this after you've thrown Tobradex ointment and a variety of different lid scrubs, lid hygienes, and it's just continuing to recur? So here's again a common scenario. So let's talk about oral antibiotics. We've got 5 classes of oral antibiotics that are available to us. The fluoroquinolones are the one that I'm going to talk about first, because this is the one we don't use for these particular situations. And why don't we use oral fluoroquinolones? The answer is because we have topical fluoroquinolones that do a great job for the eye and eyelid, and they're directly applied to the eye. We're fully aware of what topical fluoroquinolones we have. There have been some reports, and just need to keep this in mind, and these are some of the little tidbits that I tend to keep in my mind when I'm writing these medicines. Again, I'm a clinician. I'm not a pharmacist. I'm not a pharmacologist. I'm in the trenches where most of you practice as well. But oral fluoroquinolones have been reported to cause some loose connective tissue damage, in particular tendons and aortic involvement, in particular aortic dissection. Soft connective tissue, loose connective tissue is functionally impaired to a degree when individuals who are on oral fluoroquinolones. The question then becomes, what about patients who are on long-term topical fluoroquinolones? Do we have these same types of complications? Obviously, systemic absorption is going to be significantly reduced. And realistically, as far as I can tell in the literature, there were only 2 possible cases reported of systemic soft tissue or loose connective tissue involvement from topical fluoroquinolones. So that's all I'm going to say about fluoroquinolones from an oral perspective, because we just don't use them that often. So when we're going with oral antibiotics, we have many choices to pick from when we're talking about anterior segment involvement. And again, being a clinician, there's some pharmacology that we need to know. These are the things that stick in my mind. We've got the penicillin category of antibiotics. These, across the board, inhibit bacterial cell wall synthesis. And as we know, bacteria can't survive without an intact cell wall. So these medicines are characterized as being bactericidal. And it's the beta-lactam ring that is necessary for antimicrobial activity. Now, of course, with natural selection and bacteria changing over decades and centuries, there's a natural selection process where some bacteria produce beta-lactamase. And this beta-lactamase, we also call penicillinase, can damage that beta-lactam ring. And by damaging and inactivating the beta-lactam ring, this penicillinase ultimately reduces the efficacy of several penicillins. So when we're using drugs in the penicillin category, we need to be aware of the fact that penicillinase exists. What are the most common bacteria that live on the eyelid? It's Staph aureus and Staph epidermidis. And both of those often produce beta-lactamase. Okay, so the most common pathogens produce a defense mechanism against penicillins. Now, dicloxacillin and methicillin generally are beta-lactamase resistant. That's something to keep in mind. Ampicillin and amoxicillin have very broad spectrum of activity, but they are not penicillinase resistant. That's why there's a medicine that we call Augmentin. Augmentin is amoxicillin with clavulanic acid. Clavulinate is a penicillinase inhibitor. Okay, so when that clavulinate is added to a medication, it negates the effect of penicillinase. All of the penicillins are available in generics, and those generics are relatively inexpensive. Okay, now there's good and bad with each medication. Major side effects from penicillins are typically allergic hypersensitivity reactions, which can range from type 4, the most common, to type 1 acute anaphylactic reactions. Now, if we're putting patients on oral antibiotics, it's not uncommon for there to be some type of disruption of the intestinal flora with resultant upper and lower GI disturbances. Upper GI disturbances typically in the form of nausea, lower GI disturbances typically in the form of diarrhea. Usually a couple days doesn't make a difference. If we're on it for a couple of weeks, that can change things a little bit. What are the penicillins that we have available to us? Again, there's no wrong way to do this. There are a lot of them. General penicillin, 10 VK, has been around for years and years and years. Typical dosing, of course, dosing is going to vary depending upon the age, the size, the weight of the patient, other comorbid diseases, but typically penicillin, PenVK, is administered 1 gram a day, usually in divided doses, 250 QID, 500 BID. Dicloxacillin, same thing. It's usually 500 milligrams on a BID basis. Augmentin comes in several concentrations. We'll talk more about that in a little bit, but the standard dose for the majority of our patients who are going to go on Augmentin is 500 milligrams of the amoxicillin on a BID and sometimes up to a TID basis. Other options available, again, we'll get there in a bit. So that's one category. That's the second category. The third category are cephalosporins. As you know, cephalosporins are derivatives of penicillins. They also interfere with bacterial cell wall synthesis. Therefore, they are also characterized as being bactericidal. They also contain a beta-lactam ring, so they're very similar to penicillins, but this beta-lactam ring is derived from different amino acids, so they function slightly differently. And of course, that natural selection issue in that with bacteria, in that some bacteria produce beta-lactamase that can deactivate penicillins, but they may or may not deactivate cephalosporins because they behave in a slightly different fashion. So we need to be aware of beta-lactamase. There are 4 iterations, generations, if you will, of cephalosporins, the first, second, third, and fourth. The first generations, they're all relatively inexpensive. They're all available in generics. Generally, the first ones, the ones that have been around for a longer period, are a little bit less costly than the fourth generation fluoroquinolines. And I'm going to just throw this out there. We all wrestle with prescription meds being covered or not covered. And we oftentimes have to play a game with, well, this one's going to cost the patient too much out of pocket. So what is our plan B? And that's given in the world in which we practice. Hypersensitivity is also a common problem with cephalosporins. Okay, with type 4, again, delayed hypersensitivity being the most common, and acute anaphylactic-like reactions being the least common. Because cephalosporins are structurally similar to penicillins, it's estimated that about 5 to 10% of patients who are allergic to penicillin will cross-react to cephalosporin. So then the question becomes, all right, if we have a patient who has an allergy to penicillin, can we use cephalosporin? First thing we need to do, and I see this all the time, is a lot of patients will say they have an allergy to penicillin. Well, if you ask them what the what were the manifestations of the allergy? Well, they got nauseous. Well, that's more of a toxic GI reaction. That's not truly an allergic reaction. So assuming that this patient has a true allergic reaction to penicillin, how do we know when to prescribe cephalosporins? All right, so we need to be careful. They are not contraindicated in individuals with allergies to penicillin. However, the general rule of thumb is that those individuals with a more severe allergic reaction to penicillin are more likely to cross-react with those cephalosporins that we put them on, whereas those with less severe reactions are less likely to do so. So we really need to query the patient as to the severity of the allergic reaction that they had with penicillin. More severe reaction with penicillin, I'd avoid a cephalosporin. Less severe, probably okay to use them. Just like penicillin, cephalosporins can also disrupt the normal intestinal flora with the same type of GI disturbances. You need to keep in mind that cephalosporins also can disrupt the bacteria that are necessary for the synthesis of vitamin K. This in turn can result in impaired clotting. Why is that important? That's important because we have a lot of patients who are post myocardial infarction, post cerebrovascular accident. They have, for example, atrial fibrillation, and they're on medications to thin them, anticoagulants. So we can impair clotting and make those things even worse, the impaired clotting. We can make these patients bleed easier when they're on cephalosporin. So that's something to keep in mind. We've got several different cephalosporins that we can use. Keflex is probably the one that I use most frequently. I think a lot of docs use that, but keep in mind there are other options out there. Okay, that brings us to the fourth category of oral antibiotics, and these are macrolide antibiotics. These are different animals altogether. All right, these drugs chemically have a large macrolide ring, thus their name, onto which are attached a variety of sugars, and that's what gives them the antibiosis power. These, however, work on ribosomal protein synthesis. In other words, these don't break down the cell wall. They interfere with protein synthesis inside the bacteria, so the bacteria more or less malfunctions. That's why these tend to be bacteriostatic rather than bactericidal, although in higher doses they can have bactericidal effects. Okay, macrolides generally are effective against both gram-positive and some gram-negative bacteria. They're very effective against chlamydia, so that's a great use for these medications. Erythromycin is one type of macrolide antibiotic, and interestingly, erythromycin also has some anti-inflammatory properties, which makes it a good alternative when tetracyclines, which are also very anti-inflammatory, are contraindicated. So we have a patient, and we'll get to this in a bit, who we want to use a tetracycline for, but they can't tolerate a tetracycline. That's where erythromycin may be your plan B option. Across the board, generally, macrolide antibiotics are relatively safe. Not surprisingly, these have effects on the GI system: nausea, vomiting, diarrhea. Some of them, in particular, EES 400, is an enteric-coated form of macrolide, erythromycin, that is much easier on the digestive system. So what macrolides do we have? What can we use? Erythromycin, straightforward 250 milligrams on a QID basis. There's EES 400, or erythromycin ethyl succinate. This is the GI-friendly form that's enteric-coated. A little bit different dosage here. It's 400 milligrams on a TID basis. There's delayed erythromycin. There's long-acting erythromycin. We've got several different types of erythromycin. We also have clarithromycin, which I think is the sleeper macrolide. This is the one I use primarily. Clarithromycin, brand name is Biaxin. It's 500 milligrams, typically on a BID to TID dosage. We'll get into the specifics of why I use this in a minute. We're probably most familiar with azithromycin, which is a macrolide antibiotic. And as we know, azithromycin comes in, multi-dose, 250 milligram tablets. It comes in a Z-pack. It comes in a tri-pack. And we can use actually a single 1 gram dose, which is very effective for treating chlamydia and the patient's partners who also should be treated. So we're familiar with azithromycin. What about azithromycin head-to-head with erythromycin? Well, the reason why azithromycin became much more beneficial to use from a clinical perspective is that it has increased absorption rates. It has a longer half-life. It's generally better tolerated for the majority of patients as compared to erythromycin and requires less frequent dosage. All of those play a role in why patients generally tend to comply better with azithromycin versus erythromycin. I throw this up there, macrolides and Big Macs. What do Big Macs have to do with macrolides? We have a cholesterol problem in the United States. A significant number of patients have elevated cholesterol, and most of those patients, to one degree or another, are treated with statins. There are a variety of different medications that can be used to manage cholesterol, sequestering agents. We've got biologics now that are very effective, but statins tend to be the workhorse. Problem is that statins have interactions with multiple medications, one of them being macrolide antibiotics. Basically, the macrolides interfere with cytochrome P450, which ultimately prevents the metabolism of the statin in the liver. We know the statins work at the level of the liver. You get toxic levels that increase in the vascular system, and this in turn affects the EKG. And basically, this gives the individual an extended QT interval, which is essentially a form of ventricular fibrillation. That's why you'll get an e-scribe warning about not using macrolides in individuals who are taking statins. This also pertains to individuals who are taking oral antifungals for exactly the same reason. So keep that in mind when we're using macrolides. Now that brings us to antibiotic category number 5, which are the tetracyclines. Now, the tetracyclines are really the preferred antibiotics for chronic lid disease. And I cannot stress this word enough. Tetracyclines are preferred for chronic lid disease as opposed to acute lid disease. What are the chronic lid diseases that tetracyclines are very good for? Meibomitis, chronic blepharitis, case that we started off with, individuals who have recurring hordeola, recurring chalasia. Tetracyclines are also beneficial in certain cases of recurrent corneal erosions, and I'll get to that at a later slide. But I want you to keep in mind that acute hordeola are better treated, and acute eyelid infections are better treated with macrolides, cephalosporins, and penicillins. And there are several reasons why that is the case. Okay. In addition, let's go back to tetracyclines for a second. In addition to the antibacterial properties, tetracyclines have relatively potent anti-inflammatory properties. And there's multiple mechanisms of action of how these have anti-inflammatory properties. They inhibit PMN's white blood cells. They inhibit matrix metalloproteinases. They inhibit collagenase. They reduce inflammation. They inhibit lipase production by staph. This results in a better, more stable tear film. The problem, the downside with tetracyclines are multiple. Number one, their antimicrobial properties are significantly limited by a relatively high resistance rate. So if you have an infection that is causing a lot of inflammation, tetracyclines are good. If you have an infection that is not causing as much inflammation as it is causing a problem from an infectious perspective, they are not good because there's a high resistance rate. Furthermore, tetracyclines are not greatly absorbed from the digestive tract. And furthermore, they tend to bind to calcium-containing foods such as dairy products. That's why these are recommended to take on an empty stomach. Tetracyclines also tend to accumulate in calcium reservoirs in the body, which is basically our bone and teeth. And this is why they're contraindicated in children who are developing their adult teeth. We're very aware of that. What are the tetracyclines that we have available to us? It's basically tetracycline, doxycycline, and minocycline. Across the board, we have more problems with tetracycline, less with minocycline. Okay. GI toxicity, not surprisingly, is a common problem. I practice in coastal North Carolina. Photosensitivity, especially in the summertime, is rather significant in especially the fair hair, fair skinned individuals who are on tetracycline. Tinnitus and vertigo tends to be an issue with certain tetracyclines. And although IIH has been implicated in tetracycline use, it's generally exceedingly rare, although it does have a higher likelihood of being an issue if you have a patient on minocycline. Okay, here's an important piece of information. We often see patients, obviously, who have diabetes, various stages of diabetes, and those who are impaired renally, we need to keep in mind that tetracycline is cleared through the kidneys. So that's going to throw off bun and creatinine levels. So we have to be very cautious when we're using tetracyclines in individuals with impaired renal function. Doxycycline and minocycline are cleared, on the other hand, through the GI tract. And these can be used more readily in patients with impaired renal function. Keep in mind that tetracycline can also enhance Coumadin activity. So what are the tetracyclines, plural, that we have available to us? Standard dose tetracycline 250 on a QID basis. I really don't use that much. I would venture a guess that the majority of the listeners in on this webinar probably use doxycycline 100 milligrams or maybe even 50 milligrams on a BID basis, because that has been the golden child of antibiotics to use for chronic lid disease. If you get nothing from this lecture, take this home, minocycline, and you need to try it. Minocycline 50 milligrams on a BID basis has some distinct advantages. Number one, it's almost 100% absorbed. It has an extended half-life, especially in prolonged diseases such as chronic blepharitis, and it is also safe in renally compromised individuals. But the big kicker with minocycline is that it has extended mean inhibitory concentration bioavailability. In other words, when we give a patient multiple doses over a week or two of minocycline, the minocycline at MIC levels still remains for about another week or two beyond the therapy. So individuals who we're treating on a chronic basis, 4, sometimes 6, sometimes 8 weeks, are better off treated with minocycline, because once you stop the minocycline, they're still going to get an effect from the already absorbed minocycline for another couple of weeks. That plays a huge role in reducing the recurrence rates for a variety of chronic anterior segment inflammations. Now, minocycline has been implicated, to put it that way, to be a neuroprotective agent. But in reality, the studies as far as neuroprotection have all been lab-based studies looking at, ligated and cut axons. So there's really not a whole lot of data to support that from a practical perspective. And I go back to when Alpha-GAN first came out. Alpha-GAN first came out and said, the marketing folks said, well, this is a great neuroprotective agent. My question is, how the heck do you prove neuroprotection? Alpha-GAN works for glaucoma patients because it reduces IOP. Maybe it has some neuroprotection. I don't know. Hard to be firm on that. Same thing with minocycline. Maybe it has some neuroprotective properties, but again, somewhat hard to prove. So that's the basic 5 levels of antibiotics. We don't use oral fluoroquinolones that much. So when do we use them? Which ones do we use? And this is what I do. And I would suggest that you at least consider this. Separate lid infections into acute versus chronic conditions. And that can guide you onto which antibiotic to use. Acute conditions are going to be a preseptal cellulitis, a hordeolum, an acute infection, a lid laceration that has gotten infected. Chronic situations are going to be that chronic recurrent recalcitrant blepharitis, recurring hordeolum. If we're dealing with acute lid infections, I don't use oral tetracyclines. Again, because as I said, they're poorly absorbed. There's a lot of resistance to them. They just don't have great antibiotic properties. They got great anti-inflammatory properties. So for patients coming in with an acute eyelid condition, sometimes I'll use PenVK. PenVK is dirt cheap, and it's just $2 or $3, I believe, at Walmart. There's not much to that. Amoxicillin. Amoxicillin is great for kitties. It's a liquid form, especially when you can get it with great different flavors, bubblegum and grape flavors. Very tolerable. Standard dose for kids is 5 cc's per 125 milligrams. 125 milligrams is roughly a teaspoon. So amoxicillin works reasonably well. Augmentin works well. And I mentioned this earlier, the middle of the road Augmentin is 500 milligrams of amoxicillin with clavulanic acid on a BID to TID basis. But as I said, Augmentin comes in a couple of different amounts. It's available as 250, 500, or 875 milligrams of amoxicillin. We have to be careful here, though, that each dose, whether it's 250, 500, or 875, also comes with 125 milligrams of clavulanic acid. Okay, so most antibiotics, for example, penicillin, if the pharmacy only has 250 milligram tablets, you can do 250 milligram tabs on a BID basis for a total dosage of 1 gram a day. However, you can't use that same math with Augmentin, because although the amoxicillin varies, the dosing of the clavulanic acid is the same. So in other words, doubling the dose of Augmentin 250 is not the same as 1 tablet of Augmentin 500, because the 1 tablet of Augmentin 500 has only 125 milligrams of clavulanic acid. The 2 tablets of Augmentin 250 has a total of 250 milligrams of clavulanic acid. And occasionally I'll use Augmentin 875 if there's a significant anterior segment inflammation. Now, that being said, let me go back 30 seconds here. I see a lot of disease patients. I see a lot of acute care patients. We get referrals into our office from the majority of urgent care clinics, and we also get a lot of hospital referrals. Depending upon what's happening and who's on call, we oftentimes get inundated with these. So I'm seeing a ton of these patients, and that'll play a bit of a role in some of the ways that I look at treating these individuals. Again, with acute lid infections, cephalosporins are beneficial, several to choose from. My favorite, probably the one that I wrote the first prescription for way back when, was Keflex. Typically cephalexin, 500 milligrams on a BID to TID basis. These are cheap, well-tolerated generics are available. A lot of times, though, I've moved now to macrolide antibiotics if they're safe, if the patient is not on a statin. And the macrolides that I typically use is Biaxin, clarithromycin, most often on a 500 milligram BID, sometimes to a TID basis. If we can't use Biaxin, then my go-to is EES 400. This is erythromycin, 400 milligrams on a TID basis. Okay. Chronic lid conditions, on the other hand, I think are best served by treating them with tetracyclines. And again, these are the chronic recalcitrant blepharitis. The treatment here is not for 3 to 5 to 7 days. Sometimes it can be up to 30 or 60 days, because our goal with recurring conditions is twofold. Number one, to end the problem that we have today, but also, more importantly, to reduce the recurrence rate. And that's why these folks need to generally be on an antibiotic for a little bit longer period of time. Remember, tetracyclines have a high problem, have a big problem with antibiotic or with bacterial resistance. I'm sorry. So the tetracyclines that we typically use, I think most of us, as I said earlier, use doxycycline, 100 milligrams, maybe 50 milligrams on a BID basis, sometimes for up to a month or two. Minocycline is what I would suggest you try, because you get a much more pronounced effect from that, including after you discontinue the minocycline. That's dosed 50 milligrams on a BID basis, again, sometimes for 30 to 60 days. And that's my typical antibiotic for that chronic blepharitis patient. Now, keep in mind, when we're prescribing PO antibiotics for several weeks duration, GI toxicity becomes a real issue, in particular, antibiotic-associated diarrhea. It's estimated that about a third of patients on long-term antibiotics will experience this to one degree or another. That brings up the topic of probiotics. A review of the literature regarding probiotics is that there are some positives to that. They help to replenish the normal GI flora, but the data is relatively limited insofar as which probiotics to use. So I'm often asked, do I recommend them? Yes. Do I have a specific recommendation? No, I don't think that there's enough data for a particular probiotic or set of probiotics. Now, the other issue we have with antibiotics, and it doesn't necessarily have to be long treatment, 3 weeks, 4 weeks, 5 weeks of treatment. This is for our female patients with yeast infections. Some women are just very susceptible to yeast infections, even after just 1 or 2 doses of an oral antibiotic. And that's where a medicine called diflucan works exceedingly well. Diflucan is an antifungal azole agent, fluconazole. Okay, it's approved for the treatment of vaginal candidiasis. It's also approved for oropharyngeal candidiasis. But for vaginal candidiasis, it's a very simple single 150 milligram one dose. And this is very effective in controlling and eliminating vaginal candidiasis. And typically, if an individual is telling me that they are prone to candidiasis, and they need an oral antibiotic, I will prescribe the diflucan to use at the onset of symptoms, which may be after the first dose of the antibiotic. It may be after the second or third day of the antibiotic, but it's very effective. For those of you who've been in practice for a while, there was a study came out in early 2000s that raised questions about the safety and effectiveness of tetracyclines. And it said, initial study said that it increased the likelihood by 100% of developing breast cancer for individuals who were on tetracyclines longer than a 50-day cumulative lifetime dose. And that spurred a lot of angst and anxiety, and further research basically shot big holes in that. And I think that right now, there's no substantial evidence to back that up. So you may hear that now and then. No question that long-term antibiotic use of any antibiotic can certainly have long-term consequences, but not certainly the increased or doubling of breast cancer rate, especially in individuals on tetracycline. Keep in mind, when we're talking about lid infections, we need to treat both internally via oral antibiotics and externally via topical medications. So the internal treatment antibiotic of your choice suggested tetracycline. In fact, I would suggest minocycline. Externally, a lot of things to do here. Tea tree oil, lid hygiene, topical antibiotics, steroid combinations. Doesn't matter whether it's erythromycin, gentamicin, Tobradex. Tobradex fixes everything. You need to throw something on the exterior of the eyelid as well. That brings up azocyte. What about azocyte? This is a topical form of azithromycin. Has a prolonged half-life. When azocyte first came out, it was touted to be an internally acting antibiotic, meaning it can penetrate somewhat into the eyelid. But at the end of the day, realistically, oral antibiotics penetrate certainly much better because that's how they work. Azocyte originally tended to be somewhat expensive. It had some nice marketing tools, but at that time, the other topicals worked just as well. And azocytes kind of made a little bit of a resurgence. Also, since I'm in the trenches and most of us are, it's not uncommon for patients to come in with eyelid infections that also have other infections. Typically, where I live, chronic sinusitis or concurrent sinusitis, whether acute or chronic, and middle ear infections. And if a patient's coming in with these things, I'm not necessarily treating those things. I'm treating the eyelid. But if those other things get better too, more power to me. The patient certainly appreciates that. Minocycline, to a degree, again, with limited antibiotic properties. EES 400 is a go-to. Augmentin is typically my go-to in these individuals because it's going to fix the acute eyelid infection as well as the sinusitis. And again, Augmentin coming in several different concentrations. If the patient also presents with an upper respiratory infection, they've got sinusitis and now they have a little bit of a sore throat, in addition to what's going on with their preseptal cellulitis. That's a very common scenario. Acute eyelid infection, preseptal cellulitis, now an upper respiratory infection. That's a great option for Biaxin, clarithromycin, 500 milligrams on a BID basis. One time for a week, maybe 2 weeks, put a refill on that. You can use azithromycin. Typically, I'm going to use either a Z-Pack, but more commonly a tri-pack. And this is one of the few instances where I will put a patient on a fluoroquinolone, in particular Cipro 250 milligrams TID for a relatively short period of time. So I don't usually use oral fluoroquinolones, but that's a scenario where that plays a role. Now, let's, again, stay in the anterior segment. Here's a different scenario. This is a patient, long story short, has a history of recurrent erosions due to a cat claw scratch to her cornea, okay? And in her particular situation, her erosions occur about every 3 to 4 months. In other words, first time cat scratch to the cornea, we treat the patient with a bandage contact lens, an antibiotic, a nonsteroidal anti-inflammatory, a cycloplegic agent. The cornea gets better, okay? But then 3 months, 4 months later, it re-erodes again, and you treat it the same way, and then 3 or 4 months later, same thing happens again. Well, what's the definition of insanity? It's doing the same thing over and over again and expecting a different result. So that's why in this particular situation, we're going to proceed with corneal debridement, polishing of the basement membrane with a burr, stromal micropuncture, and we're probably going to put an AMG on this individual. So this brings up a couple of oral medication indications here. Again, recurrent erosions have a variety of different presentations. Presentation is rather insignificant to a degree. So we have to deal with the ocular pain end of the equation, and we also have to deal with the recurrent corneal erosion. So it's important here to differentiate between corneal pain and uveitic pain because they are different. Corneal pain is more scratchy, irritated, something in my eye sensation, which ultimately leads to uveitic pain, which is more of that deep, dull, headachy, toothache-like pain in and behind the eye. We all know that the size of the corneal epithelial defect is not a good indicator to the amount of pain that the patient is in. Patients come in, with significant corneal injuries, with mild foreign body sensation, and somebody else has 2 or 3 spots of SPK, and they're whining and complaining. So we need to keep in mind whether this is uveitic pain versus corneal pain, but we also need to keep in mind whether this is new pain or old pain. In other words, was the trauma something that happened recently, or was it several days ago? Because if it's something that occurred several days ago, that's typically going to involve more uveitic pain. And then, of course, we have a question: do we use a bandage contact lens or pressure patch? So, we'll talk about pressure patching in a second. Ocular pain management, multifaceted problem. There's a lot of different solutions. We need to control and prevent the anterior uveitis. I cannot tell you the number of patients that I've seen over the years who saw somebody for a foreign body. The foreign body was taken out. They were given some antibiotics. They may have been pressure patched, or they had a bandage contact lens, but the uveitis wasn't treated. And their story when they come in 5 days after the injury is that, hey, I saw Dr. A and things got better, but then all of a sudden, all hell starts breaking loose in my eyes in really, really bad pain. That's the uveitic pain. And we need to keep in mind that acute pain and chronic pain are different animals, and they are managed differently. I thought this picture was kind of funny from the internet. That is what eye pain looks like. Yeah, well, everybody's got a red eye, or is that a pink eye? Who knows? All right. Anybody use a pressure patch still? Probably not. Not many people do. But, one of the advantages of having some gray hair and having been around the block is that I was practicing in a time before these studies came out that kind of drove us toward using pressure, drove us toward using bandage contact lenses. But there are still some indications when a pressure patch is in order. And this goes back to the individual studies that are in the mid-90s. Eric Donenfeld's group up in New York did a study, and this was backed up. The results were backed up by the corneal abrasion patching group in 97. And basically what both of these studies showed that a bandage contact lens with a non-steroidal anti-inflammatory showed just as much pain reduction as a pressure patch and this is the key point, in patients who presented without a contact lens inducing problem. In other words, if you had trauma, not contact lens related, there's really no difference in the rapidity with which the eye got better when a bandage contact lens versus patching was used. So that, you know, there really was no compromise to that. But again, I go back to the fact that chronic pain versus acute pain are somewhat different animals. And I think that this is certainly something that you may consider. I think that you may need to pull out a pressure patch periodically, not nearly that often, but in any event, if we're dealing with anterior segment pain, we need to cycloplege the eye because it's very easy to eliminate or to reduce the uveitic component. That being said, as long as a cornea is cranky, that is a stimulus for uveitis to occur. So the individual is going to have to be cyclopleged periodically. Excuse me. As far as analgesics, what kind of analgesics should we use? This goes back to how analgesics work and how pain is mediated. There's peripheral acting agents and there are central acting agents as far as analgesics are concerned. Peripheral acting analgesics, these work on the peripheral nervous system at the site of the injury. Okay, these agents prevent the formation of the pain mediators and prevent the release of the inflammatory cascade at the injury site. In other words, these abort the first steps of the inflammatory cascade. Central acting agents work an entirely different way. They block the afferent stimulation of the pain receptors in the brain. So they work in the central nervous system to reduce and mute the already existing sensation of pain once it is established. As a rule, peripheral acting agents are good for mild to moderate pain of acute onset, versus central acting agents, narcotics in particular, are more effective in moderate to severe pain once the inflammatory cascade has begun. Let's go back here for a second. We have a corneal injury that just occurred. There's not been a long enough time since the injury to release a lot of those pain mediators and initial inflammatory cascading chemicals, PMNs and tissue necrosis factors, etc. Whereas somebody who had an injury 5 days ago, who's just now coming in because their eye is killing them, putting peripheral acting agents on that eye that has already released a huge inflammatory cascade is going to help to prevent further release of those inflammatory agents, pro-inflammatory agents, but it's not going to reduce the pain that already exists. And that's an important piece to the puzzle. What are the peripheral acting agents? These are the non-narcotic, non-steroidal anti-inflammatories, salicylates in particular. The central acting agents are the narcotic analgesics. So we'll spend a little bit of time talking about that. And the best analogy I can give you is patients who undergo PRK or PTK. Think about what happens. And I was involved in refractive surgery when it first was available in the United States. And our initial impression was that when we do PTK, these individuals are going to be relatively uncomfortable. And they weren't. And the reason for that is because prior to epithelial debridement, in other words, prior to the corneal insult in the operating room, the patient was prepped with non-steroidal anti-inflammatories to help prevent the release of these inflammatory markers. So the intraoperative use of the non-steroidal anti-inflammatories really tempered down the pain that was going to come out. In other words, these patients did pretty doggone well. They had a topical nonsteroidal anti-inflammatory that had a bandaged contact lens, and they complained of mild foreign body sensation. That's not going to be the case in a patient who had a large abrasion 5 days ago that wasn't treated. And that's because these medications inhibit the initial steps. So in acute corneal trauma, it's very similar to the inflammatory process that we see in surface ablation in corneal issues. It's a recent onset of injury, a bandaged contact lens, topical nonsteroidal anti-inflammatories are instituted relatively soon. These patients do well, especially if they're cyclopleged, because this is stunting the initial inflammatory cascade. It's going to be a little bit different when patients who have an injury on Friday come in Monday morning, okay, because they thought it was going to get better, or the patient who comes in Friday who had an injury typically on Monday. These folks have a hot anterior chamber. They may do well. They may do a little bit better with a pressure patch to keep them under control. And you're not going to put a pressure patch on for 5 days and not see them. You're going to see them back in 24 hours. So these folks also get cyclopleged. I'm not saying that you need to continue using pressure patches, but I'm saying that there's going to be some instances now and then where a pressure patch may be beneficial. What about the use of oral medications in managing pain? A lot of that depends on when the injury occurred. Is it short-term or is it long-term? We have a lot of different oral agents to use. The salicylates, aspirin, and acetaminophen, those work reasonably well. We have to be careful with GI ulcers and increased bleeding times, and especially with acetaminophen in high long-term doses, hepatic toxicity. We have non-salicylates, the non-steroidal anti-inflammatories. I think most of us are going to tend to lean toward ibuprofen and naproxen, but there are others out there that work okay. These are available over the counter. Some of these are available over the counter, but these are relatively easily accessible. But I think we're all aware that a non-steroidal anti-inflammatory and another medicine, aspirin and ibuprofen, for example, do exceedingly well. As far as narcotic analgesics, I know that a lot of folks are reticent to renew their DEA license because I hear quite regularly, I haven't written a prescription for a controlled substance in over 10 years. I still do. I see a lot of these patients. And of course, there's issues with prescribing narcotics. We have 3 primarily to choose from: codeine, hydrocodone, and oxycodone. Drowsiness and fatigue is very common with these. Nausea and vomiting is very common with these. Constipation is a very common problem with these. But keep in mind, as far as the nausea and vomiting, these drugs are typically reserved for patients who are in significant amount of pain. We see these at the hospital. These individuals are already nauseated because of the pain. And if you give them an oral narcotic analgesic, chances are they're going to throw that up. And we'll talk about a way around that. But the real issue with narcotics is certainly the addictive potential. So general rule of thumb when RXing analgesics is to use a step care approach. You have to use enough to get the job done, but you don't want to use too much. Remember this caveat that somebody taught me years and years ago, which is very, very true. Comfortable eyes heal faster than uncomfortable eyes. Imagine if you broke an arm and you didn't have it set. It's going to take a long time. It'll eventually heal. It's going to heal broken, but it's going to take a lot longer to heal because of the chronic inflammation. If you immobilize the arm, it will heal faster. If you immobilize the iris, the eye will heal faster. And that's why I say, if you're going to use an oral analgesic, whether it's a narcotic or not, you need to cycloplege that eye as well. Generally, we're going to start off with non-narcotics and use narcotics if we absolutely have to. This goes back to what I was saying earlier. Standard, very effective doses for mild pain: 500 milligrams of Tylenol with 600 milligrams of ibuprofen or 800 milligrams of ibuprofen. Both of these are available over the counter. They work collectively better than each one individually. So that's something that we can use for the mild in-office pain. Once it starts to get a little bit more serious and we need to use a narcotic analgesic, then we have a couple of options. More often than not, it's going to be Tylenol number 3, which is 300 milligrams of acetaminophen and 30 milligrams of codeine. That could be, take 2 now and then 1 every 4 to 8 hours. The 2 of them stat has a benefit of making the patient sleepy. And these individuals generally do better with their eyes closed in a cool, dark environment. So if you can get them to go home and go to sleep, they generally do well. And the Tylenol with 3 certainly has analgesic properties, but it also has sedative properties. Keep in mind that Tylenol also comes with 600 milligrams of codeine, which is called Tylenol number 4. That brings us then to the oxycodone and the hydrocodone. The brand names for oxycodone, Percodan, Percocet. The only difference between Percodan and Percocet, one has aspirin and one has Tylenol. So Percocet is with Tylenol, Percodan is with aspirin, 4.5 milligrams of oxycodone. We can also move to hydrocodone. This is going to be brand name Vicodin. We'll hear this frequently. Vicodin comes in several different hydrocodone doses, 5, 7.5, and 10 milligrams, and these are combined with acetaminophen. These can be administered QID to Q3H depending upon patient's level. These are significant injuries. Hydrocodone, Lortab, again, is another option. I don't want to spend too much time on these because we're really not using them that often. Now, as I mentioned earlier, one of the more common symptoms associated with severe eye pain is nausea. So if you give a patient any anti-inflammatory agent or any narcotic analgesic, nausea and vomiting can get worse. So they're putting something in to help reduce the pain, and then they're quickly throwing it up. Years ago, there was a medicine called Meprigan Fortis that was excellent for this. Meprigan Fortis was 50 milligrams of meperidine. Meperidine is still available, and it was mixed with 25 milligrams of promethazine. Promethazine is still available. So you can write a prescription for 50 milligrams of meperidine along with 25 milligrams of promethazine. That combination is still very effective for managing severe pain in individuals who are nauseous. Compazine is the promethazine. I'm sorry, the Phenergan is promethazine. Compazine and Phenergan are both antiemetics. Compazine can be administered orally. It can be administered by rectal suppository. So again, the instances we're going to be using these is relatively infrequent, but these are options. What about Ultram? Ultram is tramadol. It has narcotic-like action on this opioid receptors in the brain, but it's not a narcotic analgesic agent. So it has, there's less dependence associated with it, less adverse side effects. Typically, it's dosed on a 50 to 100 milligram basis up to TID. We started this, and I want to go through this very, very briefly. We started this talking about a patient with recurrent corneal erosions. And typically, we manage corneal erosions on the first go round with a bandaged contact lens, a topical anti-inflammatory, maybe you throw an antibiotic in there, and we're going to cycloplege the eye. What about using doxycycline? Does doxycycline work with recurrent erosions? Well, the answer is sometimes yes, and sometimes no. We've all been down that path. Why is it recurring, even though I put the patient on doxycycline? And I think that depends on why the patient is eroding. I'm going to summarize this very briefly. There are 2 kinds of situations that present themselves when epithelium can erode, okay? And let's look at this second one. This is where the cornea and the stroma is cranky. There's a biochemical process going on here because collagenase and MMPs really are setting the stage for this inflammatory reaction. And these individuals typically have recurring erosions that have a history that goes like this. They come in on day 1 with an injury. You treat that initial injury with a bandaged contact lens, nonsteroidal, anti-inflammatory, a cycloplegic, maybe an antibiotic. After a few days, they seem to get better. The eye's feeling better. You take the bandage lens off. A day or two later, boom, they re-erode again. You do the same thing again, and the process happens over again. This is a case where the cornea is becoming re-inflamed, and there's a chemical basis, inflammation due to collagenase and MMPs, that is causing those epithelial cells, because of the stromal inflammation, to not firmly adhere down. Compare and contrast that to the individual who I presented earlier who had a cat scratch. You treat the initial defect. The patient does fine for 3 or 4 months, completely asymptomatic. Boom. And then they re-erode again. That's because in that situation, the epithelium and the basement membrane is not uniform. There's basically a step in a structural defect in the basement membrane. So you've quieted down the inflammation. It's not an inflammatory process, it's a structural problem. And therein lies the treatment, and therein lies with re-inflammations, the second category. These are the patients that generally do better with a tetracycline to help reduce the inflammation, because tetracyclines are very anti-inflammatory. Whereas individuals with structural corneal defects typically are going to do better with debridement, polishing of the basement membrane, and anterior lamellar keratectomy, throwing an AMG on the eye, because you're structurally changing things. So I don't want to spend too much time on that, but matrix metalloproteinases are the basis for the inflammatory component, and tetracyclines inhibit those. We need to make sure that the lids are clear, because if there's a lot of bacteria there, that's not going to be helping the situation. We have a lot of amniotic membrane grafts that we could use for individuals with structural defects. They all work. Everybody has their favorite AMG, matters not, whatever you're more comfortable with. But I think that's the basis why sometimes tetracyclines work and sometimes tetracyclines don't work. Now, this is another one. We're going to finish up with this particular topic. Excuse me. Now, this is one I got sucked into. This is a patient who, short version, has a history of recurrent uveitis, moved to the area. I'm treating the uveitis appropriately. You put them on atropine, you put them on a steroid, you have them follow back in a couple of days. They were self-treating, it wasn't getting any better. And what happens when patients get better on their own? They don't come back in for the follow-up. Well, this fellow eventually came back in after self-treating with my regimen for too long a period of time, with a hot chamber and now a very large epithelial dendrite. Okay, so now we have a situation where we have HSV keratitis as well as a very hot chamber. This is a patient with recurrent uveitis that has developed HSV keratitis on top, probably because we fed it with the steroid. So we've got a hot chamber, we've got a dendrite. We need to pick and choose. We know that the treatment for the uveitis involves steroids. We know that steroids, on the other hand, can make dendrites get a lot worse. Okay, so how do we deal with this? We have a dichotomy here. We need to be aware that HSV keratitis still remains a leading cause of infectious corneal blindness. So these corneas can scar down, patients can lose vision. So if I had to prioritize, I really need to put the HSV keratitis here, get that under control, while still managing and maybe cutting back a little bit on the steroids and the cycloplegics to help control, or at least cut back on the steroids, I'm sorry, to help control the inflammatory problem. So the uveitis has to be managed aggressively with atropine. You got to use atropine on a BID, QID, sometimes even a Q4H hour basis. Steroids, they're going to be cut back a little bit, But now we need to start throwing some antivirals on the eye, both from a topical perspective as well as an oral perspective. And that brings us to the topic of oral antivirals. We've got three basically that we can use: acyclovir, famciclovir, and valacyclovir. Net result is that all of these generally are well tolerated, except for the occasional headache and a little bit of GI upset. They're tolerated by the majority of patients, different dosings, but it's very readily tolerated, and it's pretty doggone effective against both herpes simplex and herpes zoster. Now, herpes, as we just said, comes in two flavors, if you will, and how we treat herpes simplex is different than how we treat herpes zoster. We'll get to that in a second. Famvir and Valtrex generally are better absorbed than acyclovir, and they have a higher level of bioavailability. That's why these are typically requiring less frequent dosing. But as I said, all three of these are generally well tolerated by the GI system. Headache, rash, a little bit of a nuisance. So how we prescribe oral antivirals is really going to differ depending upon whether we're treating keratitis or zoster. We're using the same drugs, but in different doses. Since zoster's easy, we're going to save that one for last. Let's talk about HSV keratitis, okay? Now, the role of Zovirax in the management of HSV keratitis is well documented. This is the herpes eye disease study. And the herpes eye disease study simply looked at, we had at the time topical antivirals, and the herpes eye disease study looked at the additional use of oral antivirals on top of Viroptic, which is what we had at the time for HSV keratitis. And the study looked at both management of the acute disease as well as ultimately the prevention of recurring HSV keratitis. And it was interesting. The herpes eye disease study showed without a doubt that the addition of an oral antiviral played a role if the stroma was involved, if the endothelium was involved, and if there was iridocyclitis. But the small subset of patients who had HSV keratitis that only involved the epithelium, the addition of the oral antiviral didn't do anything really more than the Viroptic did. Now, what does that mean clinically? It means that when HSV infects the cornea, it starts at the epithelium and sets up a stromal, endothelial, and uveitic reaction. If you catch it early enough, where just the epithelium is involved, technically, according to the head study, you don't really need to use an oral antiviral. The practical side to that, or the counter argument to that, is that by and large, the majority of patients who present to our office, even if it's just one day of a foreign body sensation, and the patient's pretty diligent in coming in soon after the onset of symptoms, more often than not, it's not just the epithelium that is involved. The stroma is involved. There's probably some endotheliitis, and there's probably some anterior chamber reaction. So by and large, the majority of patients who have HSV keratitis are going to go on a topical agent as well as an oral antiviral, okay? So should antivirals be used in every case? Not necessarily. If you happen to catch it with just epithelial HSV, it's not necessary, but that's really the exception to the rule. So when are we going to use it? Certainly if there's stromal involvement, endothelial involvement, uveitic involvement, especially if there's significant vision impairment likely. We're going to use oral antibiotics. If the patient's monocular, and if there's extenuating circumstances, like the case I just presented to you, where the patient was on a topical steroid for an extended period of time. So here's the key point. When we're treating HSV keratitis, the oral antiviral needs to be continued for however long it takes to get the corneal infection under control, as opposed to in zoster. In zoster, it's treated for 7 to 10 days, period, end of sentence, that's it. But in HSV keratitis, it's not just a 7 to 10 day period. Sometimes it can extend for a couple of weeks, depending on how quickly or how slowly that cornea begins to show improvement from the simplex keratitis infection end of the equation. So what kind of dosages are we going to be using? We can use acyclovir, 250 milligrams 5 times a day for however long is necessary. We can use Valtrex 1 gram once a day up to 3 times a day for however long is necessary. We can use Famvir 500 milligrams 3 times a day for however long is necessary. The key here is the dosage of the oral antiviral is maintained until there's significant improvement of the HSV keratitis. And this is going to supplement the use of your topical agent, whether you're using Viroptic or Zergan. We know that Zergan is a bit more epithelial friendly than Viroptic. Viroptic has gotten a bad name because before Zergan came about, you would get epithelial and corneal toxicity from the Viroptic, but that was typically after several weeks of using it. For an early HSV keratitis, using Viroptic for 4, 5, 6 days is really not going to induce too much epithelial keratitis. That becomes an issue after prolonged use. That's why Zergan certainly has the number of prescriptions for Zergan has increased. The problem is the price of Zergan can be cost prohibitive. So don't be afraid to use Viroptic. If you need to use it, use it. Look out for the corneal toxicity after a couple of weeks, but that's certainly a reliable statistic there. What about HSV keratitis and recurrence? How do we prevent the recurrence rates? And this is also in the HEADS study. Acyclovir on a long-term basis was responsible for a significant reduction in the recurrence of HSV keratitis, both from an epithelial and stromal and uveitic perspective. The standard dosage to reduce the recurrence is acyclovir 400 milligrams on a BID basis up to 12 months. That's pretty standard. Okay, so in a case like what we had, where we have management of, we have to deal with severe HSV keratitis, in this particular individual who also had uveitis as the initial symptom, this patient was on atropine a couple of times a day. Predforte was cut down to 4 times a day. Viroptic or Zergan, some type of topical agent. And I typically use Valtrex because it's easy. It's 1 gram on a QD or up to TID basis. These folks are followed quite regularly every 24 hours until there's been a comfortable resolution. The key with HSV keratitis, and we all know this, is identifying it early, because a lot of times patients will come in with symptoms and they don't have a classic dendrite formation, and we think it's something else, or we throw a steroid on it. We do a steroid provocative test, if you will, and boom, we've got this dendrite. These two images, I think, clearly show, if we see this clinically, that this is an early dendrite. This is picking up some rose Bengal staining. This is one that's kind of quieted down. This shows the scarring on the visual axis that can be a problem. But our key is getting on top of HSV keratitis pretty early. Now, how many patients, how many times are we going to see something that looks like this one isolated dot here that's picking up fluorescein and say, oh, that's HSV keratitis. Well, that doesn't look like a dendrite, right? I think a lot of us are going to say, well, that looks pretty benign. Well, let me show you the rest of the picture. Here's the rest of the eye. That doesn't look like HSV keratitis, but that certainly does. Is this HSV? Absolutely. What is this? This is the terminal end bulb that hasn't connected or hasn't grown any arms yet. So each of these terminal end bulbs is what this looks like, or is what this is. So this clearly is your classic dendritic presentation, but this is also a dendrite that hasn't grown legs, if you will. What are some of the hallmarks that we can see at the slit lamp that helps us to determine that this little spot here is in fact HSK? We need to look for epithelial staining. In addition to fluorescein, we need to look at either rose bengal or lissamine green staining. Lissamine green, rose bengal will be picked up by HSV keratitis. And if we look very carefully and we have good stereopsis that the slit lamp, that epithelial defect, in particular the end bulb, is going to be somewhat raised and elevated. And not only that, because HSV infections induce a lot of inflammation, there's going to be some underlying stromal haze. And in particular, you're going to see white cell migration moving into the stroma underneath this small epithelial defect. So these white blood cells tend to be very dense underneath the defect. They tend to fan out and tend to be less dense the further away from the defect we get. And if we look really carefully under high mag, a lot of times we're going to see endothelial irregularities underneath the epithelial defect, which is endotheliitis, and perhaps some small micro KPs. This is the endothelium underlying a dendrite. So you can see these changes. You have to get your microscope set right. You have to have good optics on your scope, and you have to have good vision to see this. But if you see this early on in a patient with just a foreign body sensation and a couple of isolated spots in their cornea, that sure as heck looks like HSV keratitis. So if we can get these patients on the appropriate medicines sooner rather than later, that's a better thing. Now, compare and contrast that with zoster. As I said, with simplex, we're going to be putting these patients on antivirals for an extended period of time. With zoster, it's going to be a little bit different. What do we know about zoster? 10% of zoster cases are herpes zoster ophthalmicus. The other 90% are truncal. They involve the abdomen, chest, back, whatever. Herpes zoster and herpes zoster ophthalmicus, the frequency has almost tripled in the past few years, due primarily to the increasing age of our population. And the lifetime risk of developing zoster for all of us is about 1 out of 3 patients. Interestingly, patients who had zoster ophthalmicus have a higher risk, a 4 times higher risk of having a stroke than patients who've had just herpes zoster. Okay, so there are some systemic and neurologic risks about that. What also do we know about zoster? The initiation of the oral antivirals in patients who have zoster is ideally made within 48 to 72 hours of the onset of the disease. And that is because this helps to reduce the duration of the dermatologic involvement, which from the patient's perspective is very unsightly. But more importantly, since about a third of patients with HZO develop post-herpetic neuralgia, the prompt initiation of the oral antiviral seems to reduce the post-herpetic neuralgia. So just as we had a herpes eye disease study, there's currently ongoing a zoster eye disease study. This is a NIH randomized multi-center placebo-controlled study. Simple concept. Does a 1-year chronic suppressive therapy with 1 gram of valcyclovir reduce the long-term complications for zoster? Currently, there's a little over 500 folks that are involved in this study. So the primary outcome is, can we reduce keratitis, both epithelial, stromal, and endothelial involvement, and uveitis by keeping patients on 1 gram of valcyclovir? And furthermore, does 1 gram of cyclovir on a long-term basis help to reduce the rates of post-herpetic neuralgia? The results were hopefully going to be in by 2020. It's still somewhat of an ongoing study, but how we treat zoster is pretty straightforward. Individuals go on 800 milligrams of acyclovir 5 times daily for 7 to 10 days, or they go on 1 gram of Valtrex 3 times a day for 7 to 10 days. That's typically what I use because it's simple math. Or you can use Famvir 500 milligrams, also on a TID basis, for 7 to 10 days, period, end of sentence. This does not need to continue on because I think there's not enough data to say that repeated uses definitely shorten things, because by that 7 to 10 day period, most of the dermatologic involvement is going to be clear. Now, obviously in zoster ophthalmicus, the cornea can become involved. We also need to treat the cornea with lubricants, perhaps steroids. So we need to be aware that this is not done without corneal implications, okay? But also patients with zoster, due to the postherpetic neuralgia, oftentimes there's adjunctive therapy that's involved, and this can involve narcotics such as Percodan, Percocet, but it also can involve anticonvulsive nerve modulators such as Neurontin and Lyrica. Neurontin typically is dosed on a 300 milligram basis. I get a ton of referrals in from primary care docs who sometimes, some of them put the patient on Neurontin, others will wait and see, especially if V1 is involved. But Neurontin basically is a ramp up to tolerable benefit and then a ramping down. This is in your handout. And again, I just want to make sure we cover this. Lyrica also has been approved for post-herpetic neuralgia. It's been approved for other forms of neurotrophic pain, fibromyalgia, diabetic neuropathy. Okay. Post-herpetic neuralgia really is the main problem that's associated with zoster, and that's why getting these folks on the oral antivirals quick is helpful. Neurontin and Lyrica are found to be helpful. Interestingly, Botox, botulinum toxin, has also been found to reduce post-herpetic neuralgia because not only does it block acetylcholine, the neuromuscular junction, it also blocks the nociceptive neuropeptides that are involved in chronic pain or chronic inflammatory pain. So Botox has some benefits. So here are our caveats regarding oral antivirals. With herpes simplex, we're going to continue to use topicals. We're going to continue to use cycloplagics. We're going to minimize topical steroid use and avoid it at all if we can, but we're going to put the patient on an oral medication for however long it takes to get that cornea under control, okay? And these are the doses for simplex keratitis. We're going to wean down. That's my alarm. We're going to wean down as the patient's cornea tends to improve. Chronic suppressive therapy for simplex is 400 milligrams of acyclovir on a BID basis. And with zoster, it's going to be 7 to 10 days, period, end of sentence. I think I finished right on time. That was perfect. Thanks from Wilmington. I'll be happy to answer any questions that may have come up. I was told I need to finish my talking right around at this point. So, Dr. Jen, are you here for summarizing some of the questions? Hello, anybody else? Hopefully, I'm not the only one here. It looks like there's 350 other folks here, which is wonderful. All right, I'm just looking through some of these questions, and some of these may be repeat questions, so I apologize for that. If recommending probiotics for long-term antibiotic use, how much time before taking or after taking the oral antibiotic would you recommend? I would recommend that they take the probiotic during and then for a week or so after. Again, which probiotic. I don't think there's enough data to specify that. Now that homatropine is unavailable, do you recommend cycloplegic beyond cyclogel? Cyclogel is, I think, kind of like peeing in the ocean. I live here at the ocean. It's not going to make a big difference. If a patient needs to be cyclopleged, depending upon the trauma, if we're talking about a mild trauma, cyclogel is going to be fine. If we're talking about significant trauma and a very hot chamber, we need to jump to atropine. Scopolamine was a great drug, but that also is no longer valid, or no longer available, should I say. Jen, I see that you're on. Do you have
I'm
any
here.
other questions that came up that seemed to be recurring questions, or something that needed to be answered?
So, and also we have some time too. If you have a great question that you didn't put in the chat or Q&A, now's your time. We want to hear all the questions you have. That was a fantastic presentation. Thank you for such a great review. So much information to pack into such a short time. So
it's a lot of information, and oral meds can be a very boring topic, but you have to, I think you have to kind of keep it clinically relevant. What's your plan B for a patient who has renal dysfunction and you need to put them on an antibiotic? What about a patient who's on a statin? What concerns do you have there? What about, acute versus chronic? When to use tetracycline, when not to use tetracycline? Why does tetracycline sometimes work with recurrent corneal erosions and sometimes not work with recurrent corneal erosions? Lots of different nuances here.
perfect. So let's see. So you answered the first two questions, correct?
I believe so.
Okay,
I just pulled up and that's what I saw.
Yeah. So I will keep going as I see some coming in. So, and these go back. I know that some of these might have been way earlier in the lecture. So with, with such a long lecture, there are some great questions. So do oral antivirals alone generally work well without Veroptic in the treatment of HSV keratitis?
That's a great question. And I think the answer to that is going to depend on how severe the HSV keratitis is. If it's a very small dendrite off the visual axis, relatively acute onset of symptoms, orals are going to work fine. You start getting dendrites on the visual axis that are rather large, that may have been there for 4 or 5 or 6 days. I think it's incumbent upon us, in addition to the oral, to use a topical medication. Now, here's another piece of the puzzle, and I hate to say this, but this is the reality. If we don't use a topical antiviral agent on a rather significant simplex keratitis, and it goes south or it goes sideways, and we end up in a court, I guarantee you, and I've been an expert witness in many cases, one similar to this, they're going to say, doctor, didn't you realize that there are topical medicines that you can put directly on the eye that can help to mitigate this condition? So the answer to the question is yes, you can use orals. And I do sometimes use just orals if it's relatively mild, but depending upon my comfort level, and if I think I need a little extra oomph, it's certainly not going to hurt to throw something topical directly on the eye. But whether they're getting just an oral antiviral, they're getting cyclopleged as well, because if you don't cycloplege them, the keratitis is going to induce inflammation. Their pain level is going to go up, and you got another problem that you could have avoided by cyclopleging them preemptively.
Perfect. Thank you. Does getting the Shingrix vaccine reduce our risk of HCO?
Yes. The treatment for herpes zoster is acutely dealing with antivirals and topicals, but really the treatment is getting vaccinated. However, vaccines only last for a certain period of time. Generally, they're most effective, I believe it's for about 8 years, and when the patient is over 70 years of age, I think it has been shown that the vaccines have less efficacy the older we get. So yeah, that's certainly part and parcel of mitigating the risk of developing it. But even then, a third of us are going to get shingles. And I've seen patients who've had vaccines who still get shingles. It's not going to prevent you from getting it. It just reduces your risk.
Do you leave patients on acyclovir at the maintenance dose for longer than 1 year to prevent reoccurrence? And if so, do you monitor with routine blood work?
Yes and no. To answer that question, occasionally, yes, but usually in those situations, that's a great question. And this is a judgment call. I don't have anything to back this up. They're going to go on it for a year according to the chronic suppressive therapy data. After that, they're going to have an open-ended prescription, and I'm going to tell them to use this at the first indication that they get that their eye or something is lighting up and they're starting to get some sensations. Now, will some patients do that and just use it when they start to have some symptoms, or will they just say, you know what, I'm more comfortable taking this on a regular basis? I think the majority do. And I have a family member who does just that. Never treat family members because there's so many reasons why we don't want to do that. But family members are tough.
That if you take one pearl away from this 2-hour presentation, let that be the one.
Don't do that.
So here's a great question. I saw an ophthalmologist use erythromycin ointment with oral antiviral for HSV. Do you have any reason? Do you know why, or do you have any thoughts on that?
I can't speak for why they did it. My guess is erythromycin is a very epithelial friendly ointment. So you can smear that on a cornea and you're keeping the eyelid from chafing up against the dendrite. I don't think it necessarily has any benefit from a pharmacologic perspective in reducing the dendrite. I think it has some logistics protective factor by keeping the eyelid from chafing up against the dendrite. But I'm guessing. Erythromycin is it's an effective antibiotic, but it's probably one of the more cornea friendly ophthalmic ointments. That would be my guess.
Perfect. And just to follow up, actually, there's quite some interest in the vaccine. So we just had a follow-up question. If somebody has HZO and they're asking if they should get the vaccine still or get it again, how long should they wait?
I think I typically defer that to the internist family doc, but what I'm hearing in my neck of the woods is 6 months.
Okay.
From the time that everything gets entirely back to normal, let their immune system quiet down. Let's talk about a vaccine primary dose or a booster 6 months from now. But if you do it too soon, you're just playing with fire and can reactivate everything.
Would you consider in-office installation of 1 drop of atropine adequate to assist in pain management in a patient that will be treated with a bandage contact lens for a corneal abrasion?
I believe that the patient needs to be cyclopleged. Absolutely. If they have a corneal abrasion, I don't know if it's big or small. If they have a corneal abrasion enough where it warrants a bandage contact lens, the bandage contact lens is going to help to reduce the pain, but you still run the risk of them developing a uveitis. So if it's a small defect and they're not in that much pain and it just happened earlier today or maybe last night, I probably will use Cyclogel, a couple drops in the office, see them back tomorrow. If that chamber is lighting up, then they get atropinized. On the other hand, if it's a pretty big injury, even if it was relatively soon, a couple hours after it happened, this was a work-related injury, it's a pretty significant epithelial defect, they're going to get atrophy. What's the worst thing that happens with atrophy? They stay dilated for 4 days without a uveitis. That's a whole heck of a lot better than having 4 days of uveitis and then being cyclopleged.
Perfect. And just a reminder, we do have a few more minutes for questions. So if there is a question you have, please get it in now. We're very excited and very honored to have this time with Dr. Fanelli. So this is your time to ask him questions. So keep them coming. I am monitoring all of them. So please ask any questions you might have. I promise you, if you're thinking of a question, guaranteed there's at least 1 to 10 people that have the same question. So don't be afraid to ask these. Let's see, do you dose Tylenol and then 2 to 4 hours later treat with ibuprofen, or do you do it at the same time?
I do those at the same time. So yeah, I've heard it both ways, but I personally, anecdotally, have found it to be more beneficial to take 500 milligrams of Tylenol with 3 or 4 over-the-counter Advil. So either 600 or 800 milligrams of ibuprofen at the same time, up to 4 times a day: breakfast, lunch, dinner, and bedtime. The key is with pain management, think about anything that you have that causes pain. It's easier to avoid pain than it is to get rid of pain once it sets in. Okay. You have dental work done. Great example. All right. You have a tooth pulled, you have root canal, whatever. I don't know much about dentistry, but you get stuff like that done. It doesn't feel good. So what do? They give you some type of narcotic, or perhaps Tylenol with ibuprofen, or perhaps Ultram, whatever. Here's the prescription. Go get this filled now, because you're going to be cranky later on today. And if you do that, it's easier to keep that pain away than it is to get rid of it once it comes on. So that's whether we're talking about eyes, whether we're talking about broken arms, whether we're talking about post-operative gastrointestinal surgery pain. It's easier to keep pain away than it is to turn it off once the cat's out of the bag.
This goes back, actually, this was one of the first questions asked. Do patients need to be asked if they're taking blood thinners before beginning cephalosporins?
That's a fair question. Most of the time, if our techs have done a good job, we can look and see what medications they're on. And before I prescribe any orals, certainly, and I try to do it with topicals, but I'm not as fastidious with that. But I want to take a review of their current medications. So I'll be able to see that, for example, if they're on amiodarone, a beta blocker, and they don't list it, they probably are also on an anticoagulant, because that individual, that's the classic triad for patients with AFib. There's a lot of folks running around who have AFib. There's a lot of patients running around. I see an elderly patient population who've had a CVA, and they're prophylaxed with even something as mild as aspirin. Aspirin, no, I don't mind putting a patient on cephalosporin if they're on aspirin. If they're on, for example, Xarelto or Pradaxa, Xarelto, or any of the other, there's 3 new anticoagulants. If I'm putting them on Keflex for 4 days because they have an acute hordeolum, not a big deal. But if we're looking at something more chronic, longer term, then yes, and I'm probably going to avoid them. That's why in the majority of patients, and majority of instances in my office, I can use a macrolide antibiotic. I can't use a macrolide if they're on a statin. So the 2 hangups usually are going to be statin use and anticoagulant use, or allergic sensitivity to the particular drug.
Perfect. So, thank you.
And
actually, there was a great question that kind of ties back to when we were talking about the earlier question about abrasions. Could you please review why a large epithelial abrasion needs a cycloplegic? Is it pain management to keep the iris still, or is it the risk of uveitis?
Both.
Or both.
Both, because you're going to induce inflammation. That inflammation is going to cause the iris and ciliary body to start going into spasm. The iris and the ciliary body get cranky. They're going to release cells and protein. It's a chain reaction of events. So I'm cutting off the pain before it actually happens by cutting off or reducing the likelihood of them developing uveitis. And I seriously cannot tell you I hate to say it, but it happens all too frequently. Patients are coming in for a second opinion. I saw Dr. whomever 5 days ago for an injury, abrasion, whatever, a contact lens induced something or other. The eye felt better, and now my eye, and I got this ache in my eye, and then their chambers lit up. That was preventable. That trauma induces, this is a normal physiologic response. Going back to Latin, rubor, tumor, dolor, et calor. You're going to get pain and inflammation with trauma. And in eye pain and inflammation, it's usually going to be episcleral, external inflammation due to environmental issues, or internal, usually due to traumatic issues. So I've seen so many of them. I just cycloplegic the eye because it's one less thing I have to worry about at that follow-up 2 days, 5 days, or next week.
Perfect.
And what's the worst thing that happens? If you cycloplege somebody who wasn't going to develop a uveitis anyway, what's the worst thing that happens? They're dilated in one eye. Okay, no big deal.
There's worse things.
Exactly.
What can you do if the person cannot tolerate the GI issues with doxy for MGD?
All right, so meibomian gland dysfunction, you're using doxy for the anti-inflammatory components, okay? I usually use minocycline for 2 reasons. Number one, it's only 50 milligrams. It can be used once a day. It's generally more easily tolerated on the GI system, but more importantly, it has a longer mean inhibitory concentration in the eyelid. So you can use minocycline for a week or 2, but you're going to have an effect for 2 or 4 weeks because it sticks around for an extended period of time. But minocycline is similar to doxycycline. They're different animals. They're both tetracyclines. They're similar. I don't usually use doxy. I use minocycline because I got more bang for the buck. But if a patient cannot tolerate any tetracycline, okay, that's when I will flip over to erythromycin, a macrolide, because erythromycin has pretty decent anti-inflammatory properties. So the erythromycin is really my plan B. My plan A is actually not doxy, it's more minocycline.
Here we are for our second event of today. It's the top 10 drugs, what's in your cabinet with Dr. Jim Thimons. So I'm your host, Dr. Jennifer Stewart again. It's my great pleasure once again. I feel like I've introduced you many, many times.
A few times.
to introduce my good friend and wonderful colleague, known by many of us. Dr. Jim Thimons is a 1978 graduate of the Ohio State University College of Optometry. He completed his hospital residency at the VA Medical Center in 1979 and served as the chief of optometry service until 1985. He then accepted the position of Center Director at Omni Eye Services in Fairfax, Virginia, and served in that role until 1989, when he became Chairman, Department of Clinical Sciences at the State University of New York. While at SUNY, he developed the Glaucoma Institute, a clinical research center, and served as its first director. In 1998, he accepted the position of Executive Director of TLC and served in that role until 2002, when he co-founded Ophthalmic Consultants of Connecticut, a multidisciplinary referral practice providing secondary and tertiary level care. He's received numerous awards for his service to the profession and has over 200 publications in glaucoma, dry eye, corneal and external disease, as well as refractive surgery and new technologies. He's a nationally and internationally acclaimed speaker and educator and an acknowledged leader in the ophthalmic clinical education. He serves in professorial appointments at several universities in the U.S. and has been a clinical investigator in over 20 clinical trials. it is my great pleasure to introduce a good friend of mine, Dr. Jim Thimons. So I'll turn it over to you, and I'll see you at the end for questions.
Perfect. Thanks a lot. All right, everybody. Looking forward to spending some time together this afternoon. I'm going to bang this up to the beginning. There we go. And these are the two individuals who I'm in Charlotte to go visit. These are my grandkids, and I've never given a lecture with grandkids in the background, so I'm sure they'll be absolutely wonderful. But in case you hear some screaming, it's just children, so don't worry. We're not torturing anybody. These are my disclosures, a little more comprehensive, and I think one that you want to know. I had a chance to listen into Dr. Fanelli's lecture. Jim and I have been friends for a very, very long time. And as a result, I think from a practical perspective, we've really kind of coincided and had somewhat similar exposures, I guess, over the years. And I think that's super important. One of the things I'm going to do is I'm going to try to complement what he said. As with all education, when you train, it's really critical that you have a variety of mentors who have different perspectives on the same subject, and that you then merge that together into your perspective and how you're going to practice your life clinically. And I think that's hopefully what we're going to do today. So we're going to cover some of the same territory, but from a very different sort of viewpoint, I think. And I'm anticipating we'll say a lot of the same things, but I'm going to give you some pearls that I think are valuable and will hopefully add to what Jim has already said and then take it to another level. So first and foremost, oral drugs, these three drugs, are effectively the same. I was just going to mention, Jim had a lovely discussion about the use of the drugs. I want to make it simple for everybody. There is no clinical evidence from any peer-reviewed study that shows that there's a significant difference in any of these drugs as you use them. So my admonition to all of my students, my residents, my fellows is the best drug for the moment is the one that is the least expensive and the most accessible for the patient. So the dosing for all of these is well established. All of the approved doses for everything in acyclovir, Famvir, and Valtrex were done in studies for herpes zoster. So all of the doses that you hear, the 1,000 Valtrex, the 500 Famvir, the 800 acyclovir, those are zoster doses. Historically, and I think generally from clinical sort of relevance, viral treatment is half of that, herpes simplex virus. So you want to segregate those two out. You can use larger doses. It just adds more of a concern from a general perspective because you're going to be on the drug for a long time. Why would we use it? There's a couple of different reasons that you use it, but I'm going to just jump forward with this and say something again to simplify the process. At our practice, and I have probably one of the top 5 cornea people in the US easily. He's been voted the top ophthalmologist in America 3 years in a row. So he's a pretty talented character, and he's trained out of Wills, and we've been practicing together for 25 years. We don't use topical drugs in the office, and the reason is twofold. One, the old drugs, the Veroptics and the trifluoridanes of the world, right? They were toxic to the cornea, and they made it a little more difficult, and also the dosing was Q2 hours. Very complex for patients, not very efficient. When Zirgan came out, great drug, love the drug. The problem is I don't have a single insurance that I'm aware of that we've tried to use in the last 10 years that covers it, and it's $300 to $400 for the tube. Anybody can get a script for acyclovir for less than $20 for a full course of therapy for at least a month, and sometimes you can get it for 3 or 4 months for $20. So the default drug in the practice is typically acyclovir based on insurance or Valtrex. We use 500 and Valtrex times 3, acyclovir 400 times 5. Famvir is a drug that's absolutely equal, but the problem is that nobody teaches Famvir in eye care. Ophthalmologists don't use it to speak of. Optometrists don't typically use it. Who uses it? Your internal medicine folks and individuals in infectious disease will use it as well. Is it better? Not in our world. Maybe in their world, maybe the bioavailability is better. So try to keep it simple. Make the access the important part. What you don't want to do is start a patient on therapy with Zirgan on a Friday and find out on Monday they still don't have the drug. So acute versus chronic, we'll talk about both of those. Primary lesions, I'm a big fan of using topical or oral acyclovir for those. We'll talk a little bit about the dosing process. Stromal, Jim talked about zoster, iridocyclitic. There's reasons for long-term therapy. We'll talk a little bit about that. I want to walk you through a little bit of the story about viruses and how they have become endemic, ubiquitous within the human species that we serve as doctors, and our patients are part of that. Everything starts in the beginning. This is a stage 1 or primary herpetic lesion, somewhat ulcerated. That little archipelago of vascular involvement is classic. This patient has no symptoms whatsoever. They have a couple of lesions on the lid. Didn't think much of it, came in because they thought they had a sty, and ends up as the primary lesion. By the age of 15, 97% of all people in the United States have been exposed to and have antibodies for herpes simplex. By the age of 21, it's closer to 99+%. There is a small percentage that drag through into adult life, and I'll show you a case like that coming up. And also, just sort of perspective-wise, everything you see here today, and there are a lot of patients in this, this is just my day-to-day patient base. I don't see any general eye care of any type, don't see any general optical eye care. This is a purely medical practice. I use oral agents every day in some capacity, and I have many, many, many patients on chronic therapy for various problems. So I'll try to put that into perspective relative to how you can take that to a primary eye care physician facility like yours versus maybe a tertiary facility like ours. This primary lesion, nothing needs to be done about this. This is going to go away by itself. Most of you probably had it, didn't even know you had it. Your parents may have thought you got a bug bite. That's over. Now the virus is there, and it will set in your nerve endings for the rest of your life. That's simplex. My daughter's an archaeologist, one of her many degrees, and I have some recent literature that shows that this virus has been with the human race for almost 500,000 years. They have digs that have identified DNA of herpes simplex over 500,000 years ago. So this has been a long-standing relationship. This is a level 2 version of the same thing. This is a patient who has both a multiple lesion, there's probably about 15 or 20 if you look, a little hyperemia, cornea is fine. That serosanguinous excretion that you see up top on the lid margin, classic for virus. It's not pus, it's not tears, it's this sort of intermediate phase, and it's almost pathognomonic for the disease state. This patient, if you wanted, you could easily give them a topical antibiotic in the form of an ointment just to protect them from getting a super infection because they are a little immunocompromised locally. I typically will tell them we can do it that way or we can not do anything. You will be well in 7 to 10 days without any intervention, so long as there's no conjunctival or corneal involvement at the time. And I'm going to talk to you a minute about conjunctival evaluation because I didn't hear Jim say it, so I'll add a little bit to his comments. This is more complex. This is a patient who comes in and has multiple lesions. This is a 4-year-old male child, ER call several years ago. It's probably been 7 or 8 years ago. Took this with a really old phone and never updated the image. But the concern was on the part of the primary that this might be zoster. As you can see, the distribution is a little bit skewed to the right side of the face, most periorbital. He does have a couple lesions, flank of the nose, the above the glabellar space in the forehead. Both of those are inconsequential. No lesions in the hair. Key factors, no pain whatsoever. They're itchy, doctor, and the eye's not involved. And when I started to rotate him, I saw that he had lesions on the other side of the hemifacial plane. Always, zoster is a hemifacial disease, always. Simplex can look hemifacial, but in many instances, if you look, there'll be a lesion here, there'll be a lesion down here, and that qualifies it as a simplex. But it was really the complete lack of pain. He had no symptoms, no fever, no malaise. True zoster patients tend to not be well if they are in full throttle presentation. So for him, I treated his parents very appropriately by giving him some bacitracin ointment, and mom and dad put that on 3 times a day because he was scratching. He told me, he said, they itch and I'm scratching. So they were actually getting super infected. This was gone. 10 days later, you had no evidence whatsoever. So these are all that early phase patient, right? So here's a patient who came in who's in completely opposite situation. Here's a patient who was treated with oral antibiotics multiple times, colleagues, by different doctors over the course of about 2 weeks, different antibiotics. They said he had preseptal cellulitis. This is not preseptal cellulitis. This is lid swelling benign lid swelling, because when you palpate that going from the temporal side to the nasal canthus, that upper lid has no tenderness whatsoever. True preseptal should have tenderness in order to precipitate an oral antibiotic intervention. This, though, has two beautiful simplex lesions. I simply place the patient on Valtrex 500 milligrams, PO, TID, 3 days later, much better, a week later, completely gone. This is a this is a dermatologic variation of herpes. This patient had had herpes as a child. This is the presentation that got him into the office. I tell my students and my residents that you're going to see herpes so many different ways than you were taught, that you're going to begin to believe that this is the only disease in the world. I will leave you with a simple adage, courtesy of my partner, Eric Donenfeld. Taught me 25 years ago, and I abide by this on a daily basis, and I pass it on. When you are treating a patient or somebody else has treated a patient, and I think I heard Jim say this too, and the patient comes to see you, and it's 10 days in, and the doctor's treatments are completely ineffective or almost completely ineffective, the first thing you need to think is, this is herpes, not bacterial, or this is herpes, not allergic. You will be right a significant percentage of the time. Herpes is universally a default diagnosis when it's complex. I'm going to walk you through some really complex cases here. So keep that in mind as you're treating. Don't be afraid to treat as you anticipate you should. I do the same thing. They come back 4 or 5 days later, it's not better. I switch thoughts, I switch gears, I make a decision because now I have the sort of the intelligence of time, if you to have watched something not work, and then I go forward. So in this case, oral antivirals were fine. This is a classic hidden herpes. I see these all the time. A couple comments about side effects of the drug. If you were to qualify oral agents across the board, we'll talk about a bunch of different ones today. This class is by far and away the most safe, is the safest, not the most safe, the safest of all of the oral antibiotics available to us to treat a variety of anterior segment disease. It's inevitable, though, that there will be patients who leak through, if you will. My only question to patients, do you have any allergies to medications? No. Is your kidney function normal? If they say, I anticipate it is, nobody's ever said anything otherwise, you're fine, you can get started. On the other hand, just this week, had the same case. Patient came in, notable need for antivirals, and asked the question. She said, well, I'm actually going to see my doctor. And she gave me the name of the doctor. I said, well, that doctor is a specialist. Oh, yeah, I'm going to see it because my doctor sent me to see that doctor because there's something that he found wrong with my blood work for my kidney. So that immediately sidetracked me and changed direction. I made a phone call to the nephrologist who had not seen the patient yet. I then had to call the physician. I saw that their creatinine was out of bounds, as was their BUN, and their total clearance levels were not good. So this patient's a great non-candidate for an oral drug. There, Zirgan is a reasonable option, and you can do that. That's perfectly fine. Hypersensitivity reactions, almost never. In the beginning, if you're treating a patient with zoster, you're going to get a lot of facial herpes simplex, not so much. The reason that the fourth bullet is there is because of the first bullet. I've had 3 patients who have been hospitalized with oral antiviral therapy, all of whom I knew were at high risk. I spoke with their managing nephrologist. They also agreed that we should change the dose. They recommended the dose. I put the patient on the dose, and literally 24 to 48 hours later, they're all in the emergency room. Why? Because they were having vivid hallucinogenic, almost psychedelic hallucinogenic problems related to the fact that their kidneys were not processing the drug and it was passing through the blood-brain barrier. So that's way over here to the right, colleagues. I've treated, I can't tell you how many hundreds and hundreds and hundreds of viral patients with oral agents over the last 25, 30 years that we've had them in Connecticut. And I can assure you that I have 3 out of all of that, all of whom I knew were going to be a risk, did it anyway, and they proved that this is a reasonable conversation to have. I would suggest that if you have a patient who has a question about the kidneys, call the physician and just get them on board with everything and then be prepared. This is a rare case. This shows a lot about the disease state globally. This is a 3.5-month-old, an ER call. We're on call for one major hospital and 13 or 14 urgent care centers. a bunch of nursing homes. So we got a ton of calls when we were on call. And this was a call, and I was brought in, and you can see that the baby has lesions in the mouth around the perioral space, right? And then there's also oral cavity lesions. Those are all ulcerative herpetic lesions, and they're diffuse. The lid itself is encrusted with lesions. And when I was able to get the eye open, I could see that there were lesions on the cornea, multiple lesions. This child is in full herpetic assault. Now, they're being breastfed. This is an endemic disease, and the mother's immunity should be passed on to the child because the mother was previously exposed 99.2% of the time. The query was what to do about the eye. So treat systemically, we'll go from there, because there is no data for Veroptic or Zirgan for babies. You could use it, that's fine, but I would probably recommend having the infectious disease pediatrician treat them systemically, and you'll get just as good a result. The real question was, how did this baby get this? Because they were being breastfed. So I suggested that we get blood work on the mother and check for herpes antibodies. And in fact, that was the answer to the question. The mother had no herpetic antibodies. She was one of that 0.5% of the population that had never been exposed. And therefore, she wasn't transmitting immunity. And this child had been exposed to an active lip lesion on the part of an aunt about 8 days earlier. And that's what got them to this. This is a devastating disease in kids who don't have immunity. They can die from this, and it's almost always from really severe viral pneumonia. So that said, rare moment on that side. But it does show that there are variations in how patients present relative to this bigger picture of this universal virus. Classic, right? A couple of pearls. Jim talked about treatment. I'm not going to add anything to that other than I treat this patient orally with acyclovir 5 times a day or Valtrex 3 times a day at 500 milligrams. Standard viral dose, right? HSV dose. What I will tell you is I do keep Zirgan in the office for the specific purpose of treating this lesion as a primary therapy before we start. Because if you understand the pathophysiology of herpes, in the beginning, it's an epithelial disease. It will transfer to the stroma fairly quickly. You'll get that anterior stromal haze pretty quickly. But if you catch it early, this is all in front of Bowman's membrane for the most part. So I take a cotton swab and I load it up with Zirgan and I very gently roll it across the surface after I've stained them with lissamine. And then what happens is I get that debulking of the virus because I'm picking up pure viral particles as I roll across. And then I go ahead and start. The Russian literature is loaded with some 1980s and early 90s work in cornea that basically describe the idea that you should debride this. Concept's good. The problem is, if you think about who are the patients who don't heal well, who have wound delays, well, one of them is a herpetic patient. When you have a patient who doesn't heal well, and they're 10 days out off of PRK or they've had something else done, and they're not going where they need to go, you really need to think that it might be herpes that's sort of dragging its feet through that picture. I would say the same thing here. So don't debride it completely, just gentle pressure across, just make a nice roll and pick up all that virus and take it away. And now you have 30% less virus to work against once you start treatment, okay? That's about a 10-day treatment. This is a great slide to illustrate a really important point, how viruses promulgate themselves or how they grow and infect us. So if you look at the dark pink around the margin there, that dark pink, colleagues, is active viral replication. So that's the fire, forest fire. That light pink is where the virus was and has completely killed all the cells, and they have sloughed off. There's no epithelial cells to stain there. Therefore, you have a depression. So a true viral lesion will look very much like this. If you put fluorescein on it, you'll see that there's that gutter, almost like a downflow of lava across a mountain, right? That gutter is because those cells are gone and the active viral cells that are replicating create a little higher zone. Fluorescein seeks the lower level, obviously, as we know from clinical experience, and you get that beautiful dendritiform lesion. Now, here's the rub, and I get a fair number of these. My colleagues in Connecticut are ridiculously talented. I speak to the highest level for them. I've worked with them for 20 years. They are really good at what they do. But every once in a while, they'll send a case in and say, is this a virus? The differentiation that I make in the office is fairly simple. I stain them, and if instead of a stain, like the rivulet stain with that gutter in the middle that's lava-like, instead you get the negative stain. That's either a herpes that has healed, and you have that hypertrophic epithelial remodeling taking place, or more likely, it's the endpoint of like a PRK. Because when the cornea heals, if this is your epithelial lesion, it shrinks down like this. And it's like tectonic plates coming at each other. And as they do, when they hit each other, they slope up a little and they elevate, and then they smooth off and they become regulated 5-cell layer with squamous epithelial cells on the surface, right? That's the difference. If you don't see that gutter staining, it's probably not herpes. Could be wound delay from something else. On the other hand, if they had herpes and you see that, that means you're in good shape because the wound is closed. Now you can go about treating the patient more differentially. And I would add to this that I will treat a patient like this in principle for a few days, maybe 3 or 4. If I'm not seeing the progress that I want, I will add an amniotic membrane to this. I think it's a very valuable tool. If you did it in the beginning, I couldn't argue against that. I've just found that the vast majority of patients get better really quickly on oral agents. But if I'm seeing a wound delay, the last thing you want is to let this thing go on longer than you would desire. So put an amniotic membrane on it and treat the patient through the bandage lens on top of the membrane. Or you can use a Procara and just do the same thing without the bandage lens. But in either case, I think it's perfectly reasonable. I think it's actually recommended to treat a patient where you see any wound delay with a herpetic eye. This is stromal herpes. This is another patient of mine. These little elements over there, see how they're staining everywhere? They don't have that gutter. That's because those are not true dendrites. Those are pseudodendrites due to the inflammation that's taking place in the stroma. So if you look at stromal herpes and you understand that primary herpes is the dermatologic lesion, the first level of the eye is almost always a dendrite or some form of other problem of that type on the epithelial surface. The next level is going to be in the stroma. Because if you think about the 3 diseases that are great mimickers, right? So you have herpes, which we've talked about. Herpes literally can look like anything. The other 2 are Lyme's disease and syphilis. All of them have the exact same pattern of progression. They start with a dermatologic lesion. Herpes, that little ulcerated zone that we talked about. With Lyme's, you get these big erythema migrans. I had Lyme's recently this last July for the 3rd time. So I'm pretty familiar with erythema migrans. And with syphilis, you get a chancre. Those are all dermatologic lesions. Left untreated, they will all go away by themselves, and then they will suborn into the body and start to do the damage. The next level that they express themselves at is not another derm lesion, but instead an inflammatory response, and that's what you see here. This is level 2 herpes. You've gone beyond epithelium. Now you've gone into inflammatory herpes or stromal disease or rhidocyclitis, which we'll talk about here in a minute. So this is a much more rigorous course. If you choose not to treat this, that's perfectly fine. These are not simple lesions. They're certainly treatable. I don't know a single optometrist who isn't capable of doing this, but I know people may not want to hang on to someone for 4 to 6 weeks and manage them with steroids and take care of the IOP issues and the cycloplegia and all the other factors. I get that. Not everybody wants to treat everything. But this is a lesion that's going to take patience, time, and to some degree, some experience. Steroids, initially maybe Q2, Q3. You'll start to see this melt at the margins a little. That doesn't do this. It thins. If this is the thickness of the cornea, it thins. And that's where the problem lies. That's why you don't want to see these repeatedly, because every time you have that, the patient will eventually lose 10, 15, 20 microns of corneal thickness. And I just had a lady yesterday before I took off on the airplane who came in for a 3rd opinion. And she had a depression, almost like a delon in the cornea from chronic repeated herpes. And in that delon, she had 3 clearly distinct epithelial lesions that were not resolving. And she was very symptomatic of it. As soon as I put the anesthesia in, she was fine. That needs to get fixed. So she's coming back next week. I'm going to scrape that down. We're going to put a bandage lens with an amniotic membrane, and I think she'll do much better. Okay. So this is a long-term therapy. This patient automatically is going to get 6 months, maybe a year of oral therapy after the lesion is completed. So I think I heard Jim mention that earlier, and I would echo that as well. If you're going to keep a patient on long-term, and that's perfectly fine. This is what the HEAD study recommends. The data is very clear advantage to long-term therapy. just be generous and understand that you're managing a patient's medical condition, not just their eye. The drug can have toxicity and kidneys can change. So if you want to prove that the patient has normal kidney function to continue long-term therapy, or if you take a patient off and they blow back up on you and they have to come back in, go ahead and get CBC with a diff, creatinine, and a BUN, blood urea nitrogen. If the creatinine clearance and the creatinine levels are normal, the patient's fine, to be honest. You can treat them. If they're questionable, then you need to talk to their physician before you get them on therapy. Unfortunately, this is not effectively treated by topical therapy, and neither is rhinosinusitis. Only epithelial disease is. Here's another patient. This is one of my favorites. This is the generation of tough people. This is your parents, my parents. My parents would both be in their mid-90s now if they were with us. They grew up tough. They grew up through the Depression. They grew up through II. They grew up through, this Cuban Missile Crisis. Life was not simple then, just like it hasn't been simple now. This guy came in because of his lip. And I took one look and I said, "Oh, how's the eye feel?" "Oh, it's fine." I said, "Really?" He says, "Yeah, I don't see so well right now." But he said, "It doesn't hurt much," which is classic for herpes, but herpes simplex doesn't hurt much. Another interesting thing. This is his cornea. We grafted him. We put him on oral acyclovir chronically. He was taking it 400 milligrams twice a day. And he was supposed to be on that for the rest of his life. We grafted him for herpes. You can see here what's going on. He has a dendrite in the middle of the graft. Very unusual. That means the immunology of the body is, or the infectious disease status is crushed into a perfectly healthy eye, because we don't put herpetic eyes into patients. They're screened for that. And then look what's happening in that circle around the outside of it. That yellow globe, that's graft host rejection. So he's melting. So for him, I changed the dose. I went up to a Valtrex 1,000 3 times a day. I put him on topical therapy as well with Zergad. And I put him on some steroids after we had a day or two of viral load. Because once you put that oral agent into the bloodstream, you are constantly bathing the eye in the tear film 24 hours a day. So much more effective than putting drops in, and so much simpler for the patient, right? 5 times a day, 3 times a day versus that. This patient actually came in at about 2,200. He finished out at about 2040, 2050. He'd previously been about 2030. He lost a line or so. But he's back on oral acyclovir and knows not to do this. And you want to know how this happened? This is fascinating. He stopped his oral acyclovir, which in and of itself may or may not have been the problem. Probably wasn't the problem. But what he wasn't, because he couldn't get his insurance to cover it. What was the problem was he kept using his steroid. So he's an active viral patient. And as Jim mentioned earlier, he had a steroid challenge and he didn't do well. This is him using prednisolone once a day, because a graft like this probably needs to be maintained pretty much for a lifetime. So another variation of herpes, stromal herpes. But I want you to look at this. This is very important, colleagues. There's a white line at the margin of the stromal lesion, right? So that white line is absolutely important. He has an 8 millimeter epithelial defect over the top of a stromal lesion. Very, very, very atypical. He came from a hospital. This was another call. This was actually a Thanksgiving Day about 6 years ago. And at the end of the day, that is a large corneal ulcer. So he has super infected his viral lesion with MRSA. So that was a MRSA ulcer. So I treated him with Vanco Fortify at 50 milligrams per ml. And I covered that with topical tobramycin at 14 milligrams on the gram-negative side, just to be sure. We cultured him off. He came up positive for MRSA. I put him on oral antivirals. Didn't do anything to the cornea long-term with steroids until we cleaned up the lesion. He cleaned up in about 7 to 8 days. The wound cleared down nicely. Put him on some steroids. This eye, one of my great successes in the history of treating a lot of patients, ended up at 2030. And I am delighted to say that he and I still talk to each other. He calls me every Thanksgiving to say thanks for saving him, because I think that I was pretty much lost if we hadn't figured out what was going on. So another variation, super infection occurs in herpes, both simplex and virus, and simplex and zoster, simply because the body's immune system is depleted. The number one cause of herpetic outbreak, and probably zoster to some degree now, is the simple fact that stress mediates both of them. very actively. And if you look in your practice and you look at the roll call of viruses over the course of a year, the vast majority occur between Thanksgiving and January 1st in our practice. That's a disproportionately large number because stress pushes that envelope. This is a patient who was treated by another doctor for almost 2 weeks with topical antibiotics, no notable improvement. You can see they have tons of BK. The eye is pretty much lost to function, but that lesion wouldn't clear up. And the reason it didn't clear up is it's herpes. So I put her on oral antivirals, and about 3 or 4 days later, she was much, much better. This is an iridocyclitic one, and I want to comment on this very importantly, okay? This is critical. Iridocyclitic herpes is a unique version of uveitis. It is a uveitis, the big picture uveitis, but it's very narrow, it's very vertical. 3 things typically come at the same time. First and foremost, when you look at the KPs, they don't go like this. They don't make that triangle that we typically see. That's called an Arlt triangle, A-R-L-T apostrophe S, Arlt triangle, right? That Arlt triangle is because of the flow patterns of aqueous as it rolls up and then comes down, settles on the lower half of the cornea, that beautiful pattern. Doesn't look like that at all. It looks like somebody took a Christmas cookie cutter and stamped the cornea and then sprinkled it with powdered sugar. There is no slight diversion left. It's very circular. And when you look at this, look at that lesion right there. See those KPs? Look how much thicker the cornea is right in front of us. This patient's moving into stromal herpes. So the other version of inflammatory herpes. The third factor, and this is really the wow factor, and you've probably treated one of these, maybe 2 or 3, you don't even know it, because they do respond well to steroids as the treatment. But sometimes you end up blowing up a dendrite, and then you realize that you end up having a herpes eye. It's unimportant to the bigger picture, but we've probably all treated a couple of these successfully without knowing it. But the key that really pushes you over the edge, besides those 2 identifying factors, is the third, that one, right? The third one is almost always at the very beginning of this, the IOP in that eye will be much higher than it is in the untreated eye. As you know, in almost every other uveitis you've ever seen, the IOP is less than the uveitic eye initially. Why does that happen? Herpes simplex produces trabeculitis. The trabeculum swells, pressure goes up. So now you have a uveitic glaucoma to go along with the inflammatory problem that you have. And you need to treat both. So a couple of pearls there. If you're going to treat this, the one drug that you don't want to, well, 2 drugs you shouldn't use. One drug is a prostaglandin. If you're going to treat it chronically, if you're going to treat it for 2 days, it doesn't matter. But if you're going to treat it chronically, you really have to watch the prostaglandins because they can incite continued or progressive inflammatory changes. The second drug, which is a little bit of a quiet secret, is CAIs. What's the mechanism of the CAI? It's a carbonic anhydrase inhibitor. So as an inhibitor, it's going to block CA. Guess what the primary mechanism of cellular activity is in the endothelium? Carbonic anhydrase. So as you block that, you allow the cornea to swell slowly over time. Not a good look. So beta blocker, alpha agonist, excellent drugs for this. I wouldn't use Zimbrinza, CAI, wouldn't use I wouldn't use brinzolamide or Iza. Just stay with the beta blocker and the alpha agonist. If you need to, you can use an oral agent because that doesn't really impact this the way a topical drop does. So another alternative. This is 6 months, maybe a year of oral antiviral treatment after you've finished, and be prepared for this to pop back. One of the pearls I can pass on after treating hundreds of these over time, taper down very slowly. So as you go down 4, 3, 2, 1, get down to once a day of pred, and then flip them over to loteprednol, generic 0.5%. Go back up to 2 or 3 times a day, and then go squeeze, squeeze, squeeze over another couple of weeks. You'll find that as you exit more slowly, you're more likely. This has a pretty high risk of having a long-term component too. Talk briefly about zoster because there's so much to say about this. I could talk forever. Classic. This is self-identified. Patient's also not treatable. You see those scarred lesions up top? Those are 7 to 10 days old. All right. And the patient by history says it started. Once you're past 3 days, there's no purposeful point of intervening because the clinical literature does not support it in any way that you are going to help with the post-herpetic neuralgia, which is what you're treating for, or treating against, I should say. You're not going to have that. That's not going to happen. So as a result of that, you want to be sure that you catch the patient as early as possible. To that end, one of the things that's really critical is don't be afraid to get up in their hair. Patient comes in with hemifacial pain and you don't see anything on the face. First thing I do is I don some gloves and I say, look, I need to look up here, and you'll touch through the scalp and all of a sudden you find that little spot right there, or right here, or right here. So it's in that first division of the fifth nerve, or the fifth V1, right? And that's the earliest sign you're going to see is up here in the hair. If you start treatment there, the patient has a really good chance that they're not going to have post-herpetic neuralgia. This grew up in the Midwest, very famous phrase in farm world: horses out of the barn, don't bother shutting the door. There's no point in giving this patient an oral antiviral here. They will get better. You want to treat their skin? Absolutely. If they have lots of swelling, we'll talk about that in the steroid portion of this. There's a lot of ways to help them with swelling. I'll put them on a Medrol dose pack. That's been very helpful. And actually, some of the literature supports that that may be more important for post-herpetic neuralgia than anything else. This is a patient who had an episode, you can see, and he even has a sign right there on the tip of his nose that he should have some ocular involvement. And he's developed a nasty uveitis from this. And he also has a little bit of episcleritis. He's about 4 to 5 days in. In his case, we talked it over and I said, look, here's your options. And he said, I'd like to be put on treatment. I said, great. I did. He got better. It's also treated him topically with some steroids. He got better. He probably would have gotten better without the oral antivirals. But because he was on the cusp of 4 days, and because the lesions were so profound, I thought, little to lose. And he's an example of making a decision about the art of this disease versus the pure numbers. But if that first fellow, that's not a question. This one, kind of borderline. Steroids, I put him on Q3 hours for 2 or 3 days, then backed him up. He was off in 2 weeks. The eye was good, the skin looked good, everything was fine. This is a patient, again, who really doesn't require a lot because the lesions are old, but she was complaining of lid edema. You can see she's got profound edema, but the edema is because she's tearing so much because she has low-grade low-grade episcleritis, and she's just tearing a lot. So all of that edema, non-tender, don't need an antibiotic, don't need an antiviral. I put her on oral steroids, put her on Medrol dose pack. She improved dramatically over about 4 or 5 days, and she felt better from the topical agents that we used too. So this is another case where intervention, probably not timely. This is a case that everybody needs to know about. I'm going to give you a short story about how this disease has literally done this in the last 25 years. So in the past, for those of us who are old enough, I'm one. If you're over 60, you're probably old enough, maybe even in your mid-50s, but probably up in probably 60 and up. You received your total complete exposure to this disease from community-acquired disease state. That's a primary exposure. That was a powerful one. Everybody in my generation, parents would hear that the kid next door had chicken pox. They'd send the whole family over and have a little hug fest for the rest of the afternoon and try to get your kids sick so that they would get through the chicken pox all at once and not have to go through it each once at a time. And the consequences of chicken pox in general were relatively low. There were consequences, do not misunderstand. They had cardiac concerns, they had brain issues in some patients. So it was definitely important to get the vaccines, no question. Big improvement in life. But here's what happened. That primary exposure was then followed by everybody else in the community that you knew, your relatives, your grandkids, your nieces and nephews, all of those people that you had exposure to when they got their chicken pox. If you went over into that range, or even if you were in the general vicinity, you had a booster shot that would continue your immunity. So it was almost never the case, when I say never, almost 99% never, that you would see a 13-year-old with this disease. This is just immediately post-COVID, so like 2 years ago, right? And the concern here is, how does a 13-year-old get this when she's been vaccinated? Well, the reason is that community immunity is gone. We've lost it because we're vaccinating, very appropriately, vaccinating everybody. So I no longer get exposure. So if you're over 60, that shingles vaccine actually is meaningful because your primary resistance is pretty much waned. And that's the new norm for us, is that we get vaccinated in the beginning and we get vaccinated later. Now, if you don't have primary exposure, you're probably going to need to get repeated vaccinations over a lifetime, because she was vaccinated and it didn't work. There is a percentage, just like COVID, we're not at 100% respond, where they don't raise a titer high enough to tolerate re-exposure. So in her case, re-exposure produced a tragic outcome, which got a major workup. And the reason is this. This is V1, right, up here. This is V2, right through the ocular space into the base of the malar surface, extending back almost through the perfect position of the ear. V3 is the mandible. So V1 and V2, as you've seen in all the other slides, are very common. That's where most of the ocular or hemifacial zoster exists. This is something altogether different. This is a V3 infection. In an adult, a V3 is serious. In a child, a V3 can be tragic. It requires a really depleted immune system to get a V3 presentation, very depleted. Unfortunately, she ended up, well, called the pediatrician, got things started right away, sent her over that afternoon. They hospitalized her because they had the same concerns I did, that this could be masquerade cancer. This could be some form of really severe blood dyscrasia like lymphoma. You just don't know. So she had a massive workup. Thank God everything was fine. And I'll show you the picture in about 10 or 12 days later on oral antivirals. But this is a very concerning presentation. So when you see V3, you need to get the medical community involved. V2, V1, perfectly treatable within the office. And I mean, I'll notify the physician what we're doing, but they're always happy to give the eyeball to anybody other than them. This one, this goes way beyond that. But it also speaks to this larger issue. You're going to start seeing zoster patients, not who are 65, 70, or 80 years old, or who have cancer and are under chemotherapy, the chemo protocol, or they have some form of progressive AI, autoimmune system issues that have to be addressed. You're going to see instead 30-year-olds, 40-year-olds, 50-year-olds, and it's because they were vaccinated, their immunity's waned, and so they need to get revaccinated. And you need to work together with your community physicians to make sure that your patients are properly vaccinated and safe, okay? So big picture, another version of zoster which needs to be managed. There she is, got a smile, 10 days out. I have another one which I don't have in the deck, 3 weeks out. She's such a sweet kid. She went through hell for this, excuse my language, but kids at school were not kind. So, and she had to go back to school after a while. And it just really trolled her quite badly. But you know what? She powered through it, and she ended up doing it well. 3 weeks later, you couldn't tell her anything ever happened. But pediatricians are watching her because they're concerned that there may have been something that wasn't identified that allowed this to happen. So here you go. This is what we call rebound zoster. You see those big lesions up top? Those are 10 days old. He was fine. All of a sudden, woke up the next morning and he had these massive recurrences. This patient is different. This is, again, is there something beyond just zoster that's, zoster has taken advantage of the moment, what allowed the moment to occur. Look at the edema that he has around that eye. That eye is tender. It's sore to touch. It's not soft, intradermal edema. It's true preseptal edema. So this patient was placed, I put him on antibiotics. I restarted his antivirals, and we got him connected to a physician, which took more than a few days. Got him an ID consult, and they did a full body workup and found out that underneath all this, he had lymphoma. So unfortunately, good news for him is the lymphoma has been treated very effectively. The bad news is that's what put him into this. I don't have any resistance whatsoever. So for him, we kept him, I put him on, and they kept him on oral antivirals for almost 6 months until they felt that they had lymphoma under better control. So different version of zoster. And here's zoster uveitis, not much different than the others. It doesn't have that pattern that simplex does, not at all. This looks more like a mutton fat uveitis, a little bit of like a sarcoid or a syphilis or a TB type uveitis. The big picture here, though, colleagues, is you can have unbelievable pressure spikes with this. If I take all of our patients who have had tubes, med valves for non-controlled or malignant glaucoma, I would say out of this group of the zoster patients I've managed, probably 20 to 25% have ended up with a tube. So while you're perfectly reasonable to start the management of this with steroids, Don't be afraid to get a second set of eyes on this if pressure starts to play in a direction that you're not getting good response with. And remember that CAI issue I talked to you about earlier. This patient's going to be on therapy not for a week, as Jim mentioned, the appropriate dose. This patient's going to be on therapy for a very long time. Some recent data shows that when patients push back and have these recurrent uveitis, it's best to put them back on the antiviral. It's thought that these are dead viruses. That's actually been recently proven to not be true. They were able to do scanning EMs of the cornea, and they found that, or confocal cornea, and they found that they were able to identify live viruses in patients who had previous zoster, and those patients are the ones who have persistent presentation of the disease. So be very cautious with these individuals as to letting them go too far. Keep them close to the office. Watch them carefully. Make sure the pressures are well controlled. Tough uveitis to extinguish. Run that taper out as long as you can. I've had patients up at 12 weeks to run a taper out. And I've had one patient right now who she takes loteprednol, 1 drop every 2 weeks. If she doesn't do that, within 6 to 8 weeks, she's back with another zoster episode. And you don't want that to happen because this produces a very significant effect on the trabeculum. This is what zoster will do to the eye when it's left unchecked. So that's why we treat it. This is hyperlipoidosis. You see the interstitial keratitis there with the deep neovascularization. The zoster broke through the limbal margin and invaded the cornea. Corneas and zoster are really dangerous. This is an episcleritis in a zoster patient. You can see the skin looks beautiful. This is 6 months, 5 to 6 months after. She's now had 3 more episodes, and I've sent her back to infectious disease just for an overview of this to say, am I missing something? And the ID person called me back a couple of weeks ago and said, no. He said, she looks good otherwise, so we'll just keep treating this. But she bounces back. She keeps steroids with her, and she calls me, sends me a picture now and says, look, I got it back. I said, great, I'll see you on Tuesday. And you know what to do. And she comes in and she takes 2 or 3 weeks. It goes away for 6 to 12 months, comes back. But this was in the peri-infectious period, and then it has bounced back 3 or 4 times. But this is all from the zoster. Okay, this is important. We talked a little bit about this. This is why. This is a patient who had zoster. This is my first visit with him. I did not treat the zoster. You can see the lid damage. All that lid damage is from the zoster, by the way. This patient was devastated. That is a lid transplant. Actually, that's tissue from behind their ear and down towards the base of the neck there. So anyway, long story short, they now have a raging infection. This is nasty corneal ulcer. Big 5-millimeter lesion, stromal involvement with hypopyon. This is all from the zoster. And this is a patient who, you know, the whole concept, the slide before basically looks at that whole concept of keeping the zoster patient on when they have these persistent issues is absolutely valid. And they may need to be on them for indefinitely to keep the cornea in play. I've had 2 perforations present to the office in patients who were taken off of their oral antivirals. And within 4 to 6 weeks, they perfed. And the reason is the zoster virus is not always dead. And that's what I said earlier. So we see a patient like this, obviously treat the ulcer. Patient goes back on Valflex. I would pump them I'd get them a gram 3 times a day, maybe even topical Zirgan if you have it. But really importantly, this is most likely MRSA, maybe Pseudomonas. But in either case, you're going to treat very aggressively. This eye was saved. Cornea scarred a little bit centrally. The vision dropped to about 20/60, but we're able to bring it back. But now she's on chronic oral antivirals once a day. So doing well. And that's her about 10 weeks later. So nice save. It was a good save. And we talked a little bit about this. So the problem here is you get this post-herpetic neuralgia. So the patients really don't have any sense that the eye is not working. You can do a WISP test on them, and you can literally take that WISP and touch the cornea. They have no sensation at all. And I would argue that if you are going to manage zoster, or simplex, but zoster particularly, you need to do a WISP test after you are done with primary treatment and everything's kind of quieted down. WISP them. If they have 0 sensitivity, you need to watch them like a hawk. Or if you're not comfortable with that, find somebody who can work in the space, who's got some experience. Okay. Jim talked nicely about the cyclines. I'm going to take a whole different view of this. Okay. Jim, everything you said, I agree with. Don't like the dosing. That's personal. You'll find that different doses. We never use more than 50 milligrams once a day now. We have dropped from 100 twice a day to 100, down to 50. And there's lots of literature in the oral surgery base that uses a drug called Periostat at 20 milligrams a day for the exact same effect. So what are you trying to do here? You're trying to stop inflammation. You're not treating disease state infection here. You're stopping inflammation. You're blocking inflammation. Doxycycline is a great anti-inflammatory drug in that regard. But look here. These are the 3 drugs. Nobody I know uses tetracycline because of the stomach issues. Minocycline's interesting. I don't have a problem with it. I just don't know anybody that uses it. I don't disagree with Jim. It's probably a little more bioavailable. But if you call a pharmacy, you're probably going to have to wait a few days to get that, whereas with Doxy, it's universally available. But I think it's equally effective. The Oracea is a dermatology drug. It's 20 milligrams of standard oral, and it's 20 milligrams of sustained release. And then the Periostat, as I said, is most commonly used in surgical procedures, 20 milligrams once a day. So they found these much lower doses give you the same anti-inflammatory blocking effect. So MMP9 and collagenase, right? So that's important. And I think that's the use that I think is most useful right now. So I'll use 50 once a day. We never treat for more than 6 weeks. Some very, very good literature shows that the chronic use of doxycycline for long periods of time diminishes its effectiveness against these primary diseases, which it's brilliant against. It doesn't work as well in Lyme's if you've been using it for 2 years. It doesn't work as well in chlamydia. It doesn't work as well in gonococcal prophylaxis in patients who have been on it. So there's a lot of the mothers of patients who've been on it. The mother's been on it for a long time because they've passed on that resistance to the child. Rickettsia, brucellosis. I'm going to deal with the bottom, the last 3 bullets, okay? Rosacea, it's a given. I think most of us use it, understand that posterior lid disease that you see can be treated in many ways. And I think doxycycline is very reasonable. I don't live in a part of the world where I have to worry too much about the sunshine quotient. Yeast infections are not uncommon with chronic doxy, and certainly you get past 4 to 6 weeks. Patients can routinely acquire those. They're treatable, it's fine. But I think the better issue is ask the patient first if they are susceptible to that. And if they are, then by all means, don't treat them long term. Do something else. There's great evidence that a Z-Pak one Z-Pak is equal in treating posterior lid disease to 6 weeks of 100 milligrams BID PO for 6 weeks to treat the same thing with almost none of the side effects. So I've transferred almost all of my posterior lid patients over to Z-Paks. It works really well. And I would argue that it's much better for the patient, and it's probably much better for the GI system. I just finished a treatment of Lyme, I said, this summer. By 3 weeks in, my stomach was literally telling me, you put one more of those things down my throat, I'm going to quit working altogether. It took me 4 to 6 weeks to get my stomach back after being treated full dose. So it has consequences. But let's talk about what we're going to do here. This is the best use of doxycycline in the eye. And you're going to say, well, what are you doing for doxy? It's a corneal ulcer. Absolutely. This ulcer is going to get treated with vancomycin. Well, initially, this ulcer, when it walks in the door, is culturable. So I've cultured it. If I culture it, I don't bother with moxifloxacin or fluoxetine. Those are great drugs, but that and Polytrim is not going to take you where you want to go for this ulcer. Most of the things we treat at primary eye care level, those 2 drugs are great. So Polytrim for the gram-positive, excellent MRSA coverage, and then any of the fluoroquinolones have excellent gram-negative coverage. So good combination there, very inexpensive. This is not that. This is a true ulcer. This patient has a 5 millimeter lesion with about a 30% central erosion, and they're starting to develop a notable anterior chamber response, which by tomorrow, if left untreated, will be a hypopia. So I'm going to start this patient off with culture. I'm going to go ahead and put them on vancomycin. I'm going to add to that some form of gram-negative, and mostly gram-negative, I'm using moxifloxacin. It's been shown that that's almost as good as tobramycin fortified, much less toxic. It's easy to get. Here's the issue with the doxy. For this patient, you're going to use the doxycycline here not as an antibiotic, but as an anti-inflammatory. So here I will use 100 milligrams. I do use 100 milligrams, PO, BID. Okay. The reason for that is it blocks MMP9 and it blocks collagenase, both of which are tissue damaging agents in the infectious process of the cornea. You will diminish significantly the subsequent scarring and tissue loss that you would typically have with an ulcer of this type. And I think it's absolutely critical to invoke that. If you don't want to use 100, use 50 twice a day, but no less than 100. I think that's reasonable. The other thing I'll add to that is I'll put a gram of vitamin C on. You can get that over the counter. A lot of studies show that reepithelialization post-herpetic or post-PRK patients is notably improved with vitamin C. So that combination of vancomycin, high-grade gram-negative doxycycline is called the Will's Eye cocktail. It's been around a long time. I've added the vitamin C as the fourth measure. All good cornea people use that cocktail because it's very effective in assisting with the improvement of the overall infectious process, but delimiting the damage. So that's an ulcer. This is another ulcer I treated. This one took me about 8-10 weeks to get back to square. These ulcers have already started to produce hypopia on first view. This was an eye that was referred in. The multiple lesions are not making me happy, but I think the primary lesion is fine. I think the rest of it's just inflammatory. They did respond well. Anybody that I believe has a sight-threatening potential, these are not peripheral infiltrate patients, not even small peripheral ulcers, but if there's sight-threatening potential, I think the doxycycline is really a very outstanding tool for that. And also patients like this, here you go. This is an eye that you never want to see, okay? Sad to say. So this central scar has been there a very long time. The blood red eye, the fire hydrant red conjunctiva sclera is recent, as is the hypopia. So this is an eye that you need to have been around a long time ago to see, because I just told you everybody's been vaccinated for this. This is primary chicken pox of the eye with a corneal scar. Okay, they got it when they were a child, so they've had the scar forever. The hypopia and the infection are new. This is a great patient. Treat the infection. Patients hand motion and all have been that way for a long time. So you're not looking at the visual side of this, you're looking at the stopping of the perforation that's going to take place because of the neurotrophic issues. So this patient is an outstanding patient for doxycycline and high-dose antibiotic topically. Once you get them under control reasonably well for a couple of days, you're going to want to add a steroid to kind of quiet things down. Complex case, but a great example of how doxycycline saved the eye. I would tell you that every one of these patients I've shown you had a really good chance of perforating or losing significant vision. They all came back to very good levels. The doxycycline plays a significant role. This is not a good looking eye, but it sits there. And there's another patient with a nasty ulcer. So I get one of these a week, sometimes maybe 2 a month, but we have a regular diet of these, and they're complex. The doxy makes a big difference. So this is my little cheat sheet for coverage. If you have this in your thing, you'll see it pretty clearly there. So gram-negative coverage, fluoroquinolones, fortified thrombolysin. Gram-positive, polytrim or fortified vanco. Nighttime, Neosporin ointment, colleagues. If you're treating ulcers with doxycycline, without, whatever you prefer, I would strongly recommend that you treat vision-threatening, any corneal lesion with vision-threatening issues or wound delays of any type, doesn't matter. Even if it's a herpes virus, wouldn't put them on the doxycycline if they're not getting better as rapidly as you think they should. Neosporin ointment is a great drug. The reason is we quit using Neosporin almost globally for the eye, probably 25, 30 years ago, because there was so much toxicity from it and sensitivity to it. Well, those patients have passed through the system. The new patients haven't ever been exposed to Neosporin unless they were using it on their skin for a skin lesion. So in that regard, this ends up being a very important drug at a very important time. I can't tell you how useful that is at night in a patient who's on topical therapy. Instead of having to get up at night, just put a big dose of it in there, get it in, make sure it stays, load them up with the vancomycin and the fluoroquinolone 2 or 3 times, 4 times in the last hour before bed, put the neomycin on. And then I think your Neosporin on, you're going to end up with a much better outcome. So Jim talked a lot about these as far as drugs. I just want to show you a couple pros, okay? Yeah, let's talk about some pros. In the larger picture, almost all preseptal disease, which is what you're going to treat mostly, preseptal of one type or another, aureola, whether it's true preseptal, puncture wounds with infections, those kind of things, almost always they are gram-positive. If you look at the normal flora, it's 90%, 85 to 90% staph epi and staph aureus, right? Those are the two. Really, really, really small Pseudomonas, 0.5, probably 1 to 2%. Pearl, if a patient has a puncture wound of the eye or the lid versus a naturally acquired infection, now you shift over and now you can get Pseudomonas. More likely it's going to be strep. So anytime you have a wound that produces a preseptal, the organism is probably not going to be staph. Well, it might be, but it's more likely you have to at least be concerned. So be aware that there are variant organisms based on etiology of the problem, okay? Now, body depots, skin, hands, everybody has depots. This is the microbiome we live in, right? So each part of your body has a different organism that's common. In the lids, it's gram-positive. Nasopharynx, here and up, gram-positive. Kids, same place, Haemophilus, right? And strep. Adults, almost never Haemophilus and strep. Oropharynx, gram-positive. Stomach, Helicobacter pylori. By the way, you want to treat tough rosacea patients and succeed, you can throw unbelievable amounts of IPLs and other topical elements at them. But if it's truly rosacea and it's not responding well, one of the things that has to happen is you need to find out where the rosacea is coming from. There's a really high correlation with H. pylori, Helicobacter pylori, and rosacea. So I will go ahead and get a helio swab. So I'll take a swab them out, send it in for an H. pylori. And if their values are extraordinarily high, you treat them with the H. pylori prophylaxis, and you will have a notable improvement in your rosacea management as well. So just keep that in mind. And then I just mentioned, kids and adults they're like lightsabers. You don't want to cross streams, lightsabers. You don't want to cross streams, all right? Kids have one set of organisms, adults have another. The beauty is that in the middle, there's a single drug that does work for both, and that's amoxicillin or Augmentin, okay? Pediatrics' most popular drug is amoxicillin because amoxicillin gives you exactly what you need, right? So Pseudomonas, Haemophilus, Klebsiella, gram-negatives. Let's show you some folks here. By the way, my drug of choice, if I had to choose one, top 10, Augmentin, 875 milligrams, PO, BID. Give them 20 tabs, that's 10 days worth. They can lose a few, drop a few, hopefully not, but if they do, you have enough that you don't have to go back and get another one, pay another copay, okay? Amoxicillin is a very good alternative drug to that. None of the other drugs are used commonly. You can use dicloxacillin. It also has intrinsic beta-lactamase resistance, but the clavulanate is really the key because it makes the drug more bioavailable. It also acts as a beta-lactamase inhibitor. So beta-lactamase is an organism, is a enzyme that the infectious disease agents have developed over time to block our attempts to kill them. So, we're thinking that the battle is one way. The battle is in both directions. We create a drug, they create a resistance. We create a drug, they create a resistance. It's inevitable that battle is going to go on infinitely. I can promptly say with certainty that when we're all gone as a human species, whenever that is, hopefully it's a million years from now, but when it happens, there will be things left on the face of the earth. One will be organisms, viruses for sure. 2, parasites. 3, insects. They'll be here forever. There's not been a species of any of those in the history of the Earth's life that has ever gone extinct. They only keep adding. Conversely, mammals are going in the wrong direction. So it's important to understand that dosing. And I'm going to have to plug into my battery power here real quick while we do this. Do that. Give me a sec, colleagues. Didn't expect it to run out. It's fully charged. Here we go. Change positions here. That's good. Okay, we're back. Now, talk a little bit about oral agents and what works and what doesn't. From a practical perspective, I advise the following. Do yourself a big favor and Pick some drugs you like, work with them. Use the same drugs repeatedly. Find out relative periods of time to onset, relative periods of patient symptomatology. You put it in first couple of days, my stomach hurts. This is bothering, but then after a couple more days, take it with some food. You need to know these subtleties because you will get those complaints. If you're using a different drug every time, you never really get a handle, as it were, on which drugs work the best. So I love Augmentin. If I'm not going to use that, Keflex is a very good drug. That's a cephalosporin, excellent drug, 250. I'll tell you about the dosing here in a minute. I've changed things around a little bit. On the whole, those two classes cover probably 95%. If a patient's allergic to penicillin, there is a crossover event to the cephalosporins that's not exhibited by the macrolids, which would be a Z-Pak. The problem with Z-Paks is they just don't work as well. They're not as effective. They've been overused in their entirety, and so their sensitivities have dropped, but they are still a reasonable agent for some patients. So this is classic patient. Went to sleep, I was fine. Woke up the next morning, I looked like this. Let me drop a couple pearls. I've countless patients. I can't tell you, probably 1,000 or more patients I've treated with oral agents over the last 25 years. And the reason I've sort of positioned these slides is the following. It's a simple test. Wash your hands or put some gloves on. Take your finger, march it from the temporal part of that lid over to the primary lesion. No pain, no pain, no pain, no pain. Ouch. That is not preseptal cellulitis. It typically does not require an oral antibiotic. Instead, what you want to do is a topical agent like a Neopolydex, which is excellent for that. Ointment. You're going to use it on the lid and in the eye 3 times a day. It's a little bit goopy, so nighttime you want to use it, you can use it at night for that, but on the lid 3 times a day. And the most important, and this is the take-home message from this lecture, you take nothing home, take this home. The best hot compress you can make. My partner and I have been doing this for 25 years together. Thousands and thousands and thousands of patients. It really, really works. Take an egg, put it in a pan, hard boil it. Take it out of the pan, hot in the shell. Do not deshell it. Wrap it in a wet paper towel, put it on the eye for 15 minutes. The egg will hold heat for a good 30 minutes, but 15 really good ones. So what you're doing is, if you don't put them on an antibiotic, you're drawing the patient's natural immune system in at about a 10 to 15 times greater rate than it would naturally be present, because you've accelerated the blood flow in the periorbital space by having the heat. One. If you use an antibiotic, you're getting the immune system of the body, and the blood serum levels are going to go through the ceiling right there, but they're not going to have to be too high anywhere else to cause problems. So I think it's a very good sort of natural flip, right? That works really well. This patient, long distance, they were on vacation at the Jersey Shore. Sorry, just a sec here. Stand up for a minute. On vacation at the Jersey Shore, I got a phone call, and the husband called and said, we're out of town. Can you help? So sent a picture. You can see she is tender for edge to edge. This patient clearly has a 2+3 preseptal cellulitis. We made sure that there was no pain on eye movement, that it wasn't postseptal or orbital cellulitis. Everything was fine. Okay. All that said, at the end of the day, she needed to be treated. So she got Augmentin 875 PO BID and a hot egg twice a day. And this is what she looked like 3 days later. She has big, beautiful eyes. That eye looked so much better. She was feeling so much better. Kept her on for a week. She used the egg the whole week. And by the time it was done, both eyes were literally identical. This is exactly what you want. That egg in combination with antibiosis works. This is a patient who came in, and she actually brought her dad in to see me for something else. And I looked at her and I said, "What's going on?" She goes, "Oh, I woke up 2 days ago. My eye really, really hurt, and it's watering." Okay, great. So we tested the lacrimal system, and she didn't have any obstruction. But more importantly, if you touch that lid, it's tender the whole way across. So for her, there was another problem. When she moved, she said she had some eye pain. So she's having a little bit of EOM pain. That patient is an automatic CT scan of the orbit. When you scan orbits, for whatever reason, make sure that you do that. And you don't need to do contrast when you do an orbital scan. The scan will show you almost everything you need without that. So just set up the CT. And here's a pearl. If you have a patient like this, and you go through normal channels, they could be anywhere from 3 to 15 days to get that CT set up. So if you really feel that they have an orbital cellulitis, if they're having pain on eye movement, and they have any type of restriction, if there's any pupil involvement or vision loss on that side, that patient should be sent to the emergency room that you typically associate with or nearest to. And before they get there, you should call the emergency room and tell them what you want. They will have a CT scan done that day, 100% of the time. I have never had anybody in an emergency room who didn't say, oh, okay, great. We'll get back to you. And they are great about getting it done. I don't pull that trigger very often because I don't want to abuse that emergency room option. But when I need it, and I did with her because her insurance was kind of crappy, to be honest, and it would have taken my staff forever. I sent her over, and in fact, she did have some inflammation in the orbit, which means that she had orbital cellulitis. That's a case that you're not managing at the office. So she was sent to a hospital-based university center, and she was actually in the hospital for 4 days on an IV, and then she was sent home on a PICC line. So she had a nasty infection. So this one's this is lovely. You see that large lesion sticking out of the bottom of her lid? Yeah, that's actually the primary lesion. So what did she decide to do? She had a hordeolum, and she decided to squeeze it. She self-drained it, and in doing so, she self-infected. So now she has a raging preseptal cellulitis and a really, really large, right, secondary lesion. That lesion is not part of the preseptal cellulitis. All right, that's just an inflammatory response to the area that she ended up involving. So she did not get an orbital scan. I was fine with that. Her eye movement was good, pupils were fine, but she was placed on treatment. This is pretty typical. It's about 10 days, hot compresses and antibiotics. Here's an even better case, all right? Look closely at the affected eye, and then very carefully look at the other eye. This is a 19-year-old guy who came in and said, yeah, this started about 4 or 5 days ago. Does it hurt? No. How's the vision? Well, when I lift my lid up, vision's pretty good. I said, when did the other eye, the right eye, become involved? He goes, that was about 3 days ago. So I tested him with the Adeno Plus, which is the antiviral test, and he came out flaming. It took about 30 seconds, and he was a pure red line in that eye, and about maybe a minute and a half in the other. This is a raging EKC. And that's where the lid edema is coming from. This is not oral antibiotics. This is topical steroids and some topical antibiotics if you want. I also peeled membranes. And then he went away because he went back to school. He was up in New Hampshire. And I said, look, let me get you connected to somebody up there. So the doctor that I tried to connect him with happened to be away for some reason. So he ended up going to Dartmouth. Dartmouth just blew him up. It was like crazy. Oh my God, you're going to die. We do all these scans, and your doctor was completely wrong. This is a really serious bacterial infection. And this was the residents at Dartmouth. And it ended up that once the cornea guy walked in and said, nope, that's EKC, and all of you need to be very careful because you've been touching this guy's eye. This is just bad EKC. That is called intradermal or subdermal soft tissue edema. And it's all because the virus opens up the blood vessels, lymphatic and otherwise, and it just allows the fluid to pour out. Sometimes you'll see that as a hemorrhagic. It's called enterovirus 70, but no oral antibiotics here. This is a case where there was trauma involved, blunt trauma. This is an industrial accident. This guy waited 5 days to come in. He was immediately sent over for an orbital scan. I couldn't see anything. I couldn't move the globe. Globe was intact. I had a B scan that showed that, but I couldn't see anything behind it. He ended up being hospitalized for this, not so much because of the infection, just because of the fact that he had nobody to help take care of him. And it was really a better option. So he stayed a couple of days. They put him on an IV. He eventually did quite well. He had a surgical repair of the lid. Everything turned out nicely. And I saw him probably about 3 or 4 months ago. He was doing great. This is a patient who I put in mostly because of his amazing hair. Love that guy's hair. I wish I could. If I can have hair like that, I'd live to be 1,000. I would love that. But nonetheless, it's really that large abscess in his upper lid. I treated him. This was a COVID patient. I never actually physically saw him in the office. I ended up getting him to an oculoplastics person about 6 weeks later. Treated it effectively with an oral antibiotic. That was an abscess. Nobody knows how he got it. He was in pain. It responded nicely. No hospital would see him for a CT scan, so I really didn't have an option. His daughter was very nice. She communicated with me on a daily basis for weeks. And he did quite well. And then about 4 to 5 weeks back, he started to have it come back again. And so I contacted an OP person at one of the hospitals that we're on staff at. And they said, look, you know what, have the daughter do a COVID test. And if he's COVID negative, I'll see him. And she ended up having to drain that manually. The oral antibiotic worked great. And then it wasn't probably quite strong enough, or it wasn't sensitive enough to that organism, and it came back. This is a great case. This is a patient who was treated on 3 different oral antibiotics and some oral steroids over the course of 6 to 8 weeks, none of which were effective. The lid was generally like this, notably asymmetric, notably ptotic, notably swollen. There was no pain on eye movement. The pupil function was normal. Visual acuity was good. This case is an absolute scan before any further treatment. And exactly what we expected. This patient ended up with lymphoma of the orbit. And once that was treated, everything returned to normal. This is all secondary fluid edema from changing the normal physiologic transfers that take place between the orbital space and the lid. So classic in everybody. This just, I put it in here because you should always look up under the lids too. There's a little white dot on the cornea. You can see it down at about 6 o'clock, mid corneal space. That's what the patient came in for, colleagues. That is a paint chip. And he was symptomatic. He was uncomfortable. I said, oh, okay, great. So we end up taking off the paint chip, and in doing so, I flipped the lid to see if there's anything up underneath. And I didn't find another paint chip, but I did find this, and that is a very, very large squamous cell carcinoma. And he had some swelling of the lid, relatively speaking, but he just thought it was due to age and really was asymptomatic otherwise. But fortunately, that eye was saved and the lesion was removed. This is MRSA. Quick comment here. I want you to look at the sensitivities over here on the left. So trimethoprim, which is Polytrim, excellent topical sensitivity. Look at the fluoroquinolones, colleagues. This is a 2008. They're actually worse now than they were before. So about 1 out of every 6 patients is sensitive to the topical fluoroquinolones that we're using to treat disease when it is MRSA. If it's gram-negative, it's almost 100%. If it's strep, it's 100%. If it's gram-positive, it's really low. So if you have a failed corneal treatment on moxifloxacin or ofloxacin, whatever you decide to use, don't give it more than 2 days. If you're not better, if you're not notably better symptomatically, I feel better, there's less pain, the lesion looks better, it's quieted down, I would absolutely assume you have a gram-positive failure, and I would switch the patient over initially right away to Polytrim, order up some vancomycin, and move them over to that too. This is a case where that little dot on his forehead was a blemish. He popped it. That was 3 days later. This gentleman was in town from Georgia visiting for a wedding, family wedding. Ended up having that happen. Just tragic disease. I couldn't see anything. We couldn't do anything. The B scan was relative negative. I mean, I could see the posterior wall. I couldn't see anything in front, but there was no endophthalmitis. Movement of the other eye did not produce incredible pain. He felt some pressure. So that tells me that the orbit was lit up in some fashion. So we sent him over to the hospital for a stat scan. I got the scan results and I called the infectious disease department. They admitted him. He was in the hospital for several days. They cultured him. He was MRSA positive. Breaking that lesion on his forehead, he self-infected himself with MRSA. So MRSA has become a ubiquitous common organism in our world. Used to be hospitals only, now it's community-acquired MRSA. It's everywhere. So be aware that if you don't get a good response, MRSA can be it. For that, a typical antibiotic is not going to be one of the gram-positive drugs like Augmentin or Caflex or dicloxacillin. Clindamycin is the normal drug of choice, 300 milligrams 3 to 4 times a day. In his case, somewhat larger individual, somewhat more husky guy. He ended up 4 times a day, but he was on, in fact, he was on IVs for 3 days and then they sent him home on Clindo. And here's what he looked like a week later, and here's what he looked like 2 weeks later. So great recovery, the eye's good, good save. And by the way, he loved it so much in Connecticut from the wedding and all the care he got, he actually moved here. So he's a patient of mine now, so we could see each other. And this is a MRSA case that's just awful. You don't want to see something bad, close your eyes on the next slide. There's a young man who, when he was 2, was pushed into a fire and never got his hands down. And he's had 147 surgeries, and he's like that. His lids don't close. He's had multiple MRSA infections of the cornea. not much to be done other than, close observation. So we watch them carefully, but tragic story, but that's the best we can do. And nobody's going to do a transplant on that. So doing our best to hold the wolves at the door, but this is a tough case. So he's been on oral antibiotics a lot over the many years that we've seen him, and he works together with another doctor down in, I'll say Washington, D.C. area. He has family down there. He goes down there at the time, but MRSA's everywhere. This is a bad one. So anytime we see it, he carries vancomycin with him. So he's a good guy. Cephalosporins, Jim talked about those. I'm not going to say much other than to let you know, these are driven by generational issues. So the best and the most important of the cephalosporins are the earliest for us, because as I told you, everything for us is gram-positive. Everything for the rest of the world can be different. So if you're doing gram-positive, you really want a first-generation cephalosporin like Keflex. Cephalexin's a great drug, really, really good. Duracef, Cefadroxil is an excellent drug. I've changed my dosing on those. I initiate therapy at 1,500 milligrams for 2 days to get a loading dose, and then I cut back to the more normal 1,000, 254 times a day. You can even use 500 3 times a day if you want. That's fine. These drugs are very effective, but they have lost some sensitivity. It's a pretty good crossover drug. There's about a 3% chance of crossing over. And don't use anything beyond first generation. They're not as effective for us because these drugs are much more gram-negative than they are positive. Let's get by that. I want to talk really quickly about steroids and then finish with something that we all need to spend some time with. Steroid use, 90% of steroids are used for scleritises and uveitis, anterior or posterior. Most nobody that I know is going to treat an inflammatory preseptal cellulitis with a steroid. They are used for progressive thyroid disease, although today there's a better option. It's called Tepezza. I've had 6 patients who have had that treatment done. It's ridiculously expensive, but very effective, and it avoids steroids. I do use them for DLK, that's deep lamellar keratitis. We rarely see that anymore, but if you have it, it doesn't always respond to topicals very well, so a Medrol dose pack's good there. But primarily, you're going to use it for either episcleritis that's nodular or very painful, or scleritis. Dermatitis is as well, and we'll show you some pics, okay? Medrol dose pack, this is methylprednisolone. This is such a great drug. There's no risk of this inducing a systemic change relative to steroids changing the normal metabolic cycle when you use this pack. This is such a cool drug. This is 90% of my use. Almost never open label a steroid. I use these instead, and they work really well. Prednisolone or prednisone you can use in various forms. Classic case. This is 4 days after the initiation of methylprednisolone. She's a lacrosse player. She fell face down onto the artificial turf and ended up having a wild reaction to it. Globes were fine, but the lids and the area around the face were horribly swollen. Eye was good too. This is her 3rd time this has happened, so we've had a long talk about playing lacrosse on turf versus natural surface. Her pediatrician has talked to her about it as well. She's actually a very gifted athlete, so she's working through that, but she has some really profound reaction to the material that turf is made from. But she worked out really well with the Medrol dose pack. Here's another case. This is a day and a half, 2 days into treatment. She is a laundress at a local facility, and she does the laundry, and the chemicals that we're using just kept causing this. So I actually had to write a letter to get her excused, but this is her 2nd time with the Medrol dose pack, and she just has this unbelievable response to external stimulus. So these are both dermatitises, and they worked well with a standard dose pack. This is a person who's very, very dear to me. It's my eldest daughter. She has developed a really profound response to certain protein stimuli. This is called mast cell recruitment syndrome, and secondary to her long career in archaeology, she had a couple of injuries that were exposed her to very, very old bacteria from the digs, and somehow that set this up. So when she gets these, a Medrol dose pack works really well. This patient doesn't have any problems at all that need a Medrol dose pack. I put it in because she came in saying, my lids are so swollen all the time. This has nothing to do with any inflammatory infectious process. Those large fat deposits are called festoons. That's Festoons. And they're simply the natural byproduct of the ubicularis muscle separating and natural fat from the orbit being moved forward. Easily repaired, take the fat, either take it out or put it back in, so the muscle back up. Patient will look 25 years younger, but it tends to be hereditary. And once you have it, if you live long enough, you'll probably have it again, but it's not anything to do with steroids. This is a amazing thyroid case. Came in with visual field loss, came in with extraocular muscle, multiple forms of diplopia, depending on position of gaze. Patient's in acute thyroid distress. His exophthalmometry was 31 on the right, and he was 29 or 30 on the left. I've never seen an eye like this. He had visual field loss. I immediately put him on steroids while we got the process going. He ended up at a tertiary facility 2 days later. We got him referred in, and they ended up treating him with Tepezza. And today the field is good. The extraocular muscles are good. It's had a couple side effects, but overall, a very good result. You can see he also has 4+ floppy lid in both eyes. This is a post-Zostra patient. I told you I use it for this. She's almost 12 days out. That edema just won't go away, so I put her on a Medrol dose pack. That worked really well. Here's a patient with acute thyroid decompensation in one eye only. Got him started on steroids also. So these are all pretty typical patients. Here's a patient I put on steroids, but the reason I put her on steroids was somebody else put her on antibiotics. So let me show you these two pictures. These are both part of the disease. This bleeding gums and this profound conjunctival chemosis, and just really profound. And what you'll see here is conjunctival chemosis is present in both eyes. I didn't show the other eye. It's so bad that she can't close the lid, so she has this desiccation of the palpebral surface of the epithelium, right? So the palpebral epithelium is exposed, so you have to treat that. I treat it with a steroid ointment, so back it down, put her on oral Medrol dose pack. But the underlying problem is she'd been treated for 3 weeks in a variety of settings for an infection of her leg. She had a cellulitis of her leg. This, colleagues, is Stevens-Johnson syndrome, SJS. It is the result of her having an allergic reaction to the antibiotics that they use to treat the cellulitis. So I'm not telling you not to treat patients. You should treat what's appropriate. But I also want to be very, very, very firm in saying, if there's not a need to treat the lid, don't treat that patient orally. We talked about how to differentiate that. You know, I take a picture of everybody before they leave if I treat or don't treat them, and then I follow them daily with serial photography to my personal phone. And I find that to be the best way to track them. 1 out of 100 break through and become worse. The other 99 get much better. But key is you shouldn't treat patients who don't require it just because there's a possibility that it's preseptal. You need to make sure that that's an issue. So this is why she responded pretty nicely to the steroids. So I'm going to jump through a couple things here. We got a couple minutes left. This is a drug. I don't know if any of you have used Oxervate or not. I have a 20+ patients on it. This is the first biologic we've had for neurotrophic keratitis, and it's not an oral drug, but it has become one of my weapons of choice for patients with really severe syndromes. We talked about treating them with doxy in the acute phase, but these patients end up with neurotrophic keratitis. Really nothing else out there. There's a new drug in clinical trials, but it hasn't been released yet. So the data shows 72% of the patients were completely healed at 8 weeks. It's an 8-week treatment. And 80% of those remained healed for up to a year. These are the kind of patients who you need to be concerned about. Total neurotrophia. You could lay the Q-tip on that right eye and she doesn't feel it. So she's melting constantly. She has issues with, she's already had a tarsorrhea in that eye and it's completely released. So she has other concerns. So these types of patients end up with corneal ulcers and other problems. Tarsorrhea is a great treatment, but if they don't want scarification, Oxervate and then tarsorrhea can be done. A lot of different options, but this is a drug you need to spend a little bit of time with. Great drug for neurotrophic keratitis, absolutely terrific. So I'd highly recommend that you do that. This is a patient I treated with a non-responsive corneal wound, which ended up ulcerating. So I treated her with antibiotics until we cleared the ulcer, but the wound wouldn't clear. And I put her on Oxervate, and this is her about 4 weeks later. And at 8 weeks out, the cornea had completely resolved after about 9 months of somebody else treating her with minimal to no success. So Oxervate can be a very good drug. Let's do this. I'm going to skip by this. I want to talk about this drug right here. This is the new hot drug in America, right? This is Dupixent. Dupixent is a great drug. This patient, you can see, has really severe eczematic keratoconjunctivitis type symptoms along with dermatitis of the periorbital lids. These are his hands. Is a young man, really handsome young guy, and he's just devastated by this disease. So he was one of my first patients. He had a mild conjunctivitis. This is a great systemic drug. I'm sure almost all of you probably have a patient on it. It's now indicated for both eczema and asthma, and it resolves both of them at a very high level with relatively small side effects. Little conjunctivitis. This is not a small side effect. One injection of Dupixent did this. She didn't look like this at all. So you, as the eye person, are going to be the number one side effect that they have predominantly. Mostly it's a little conjunctivitis treated with some loteprednol. But this is the rising tide systemic drug for the treatment of asthma and allergic complications in patients with more progressed disease. And we need to be vigilant that we're on point. Matter of fact, a lot of doctors will send them in now before they start, and they want an eye clearance just to make sure everything's normal. I get several of those a month. So be prepared for that. Then we're going to talk, there's another eczema patient. And now we're going to talk about one other thing real quick. I heard Jim talk about neuro, that I didn't think he talked about this. So I'm going to finish with this. This drug is an oral drug. Everything I've talked about is small potatoes relative to total use. In America, this drug is on a chronic basis used by tens and tens of millions of people in this country every year. Some every day, some occasionally, but this is probably one of the more commonly used drugs in America, along with hypertension and diabetes, okay? In the past, we had no material knowledge about this drug, and the reason for that was pretty clear. The reason was that because marijuana was a Schedule I drug, and we could do no research because a previous president made it a Schedule I drug to block the use of it by certain classes of individuals who opposed his political perspective. No politics involved, just stating the facts. We know it can lower pressure. It has short duration side effects, and the American Glaucoma Society says there's a lack of evidence, and that's true because there is no research, or had not been any research. This is the American Academy of Ophthalmology. They said the same thing. The Schedule I status was such a stigma that all research basically ceased to exist from 1980 until 3 years ago. They don't support it because there's no information to justify it. It doesn't mean it doesn't work. I have patients every week. I have a big glaucoma practice. I have patients at least a couple times a month, I should say, who come in and say, "Doc, I want to use marijuana instead of these drops. Can I do that?" Well, you need to know. This is in 2022 Review of Ophthalmology. This is Sameh Masad. And the other people involved in this are two really, really outstanding people, including Peter Netland, who is, I think, America's top pediatric glaucoma person. He's at the University of Virginia, super talented guy. Look at the data from this study, and we'll finish up with this, right? So, mean intraocular pressure, notable decline versus placebo. Duration of action, about 4 to 5 hours. So, at minimum, the patient's going to have to ingest and or smoke something every 4 to 6 hours all day long. And I've said that to patients, and I've literally had this response given back to me. And the problem with that is what? Okay, if that's your perspective, I'm all in. But then look at the percentage of intraocular reduction over time. It's very effective. And we're looking at 15 to, and by the way, these are not patients with glaucoma. These are patients who are college students who volunteered. Tough recruit on that study. But nonetheless, that number is in a healthy eye. They're getting 16% in a normal eye. I don't have a single drug, and you don't have a drug that's going to do any better than that in normal patients. In glaucoma patients, the response is almost 30%, so it works pretty well. Here's the piece that's interesting. Plasma levels over time. You have this spike, and then they fall, but you have a persistent post-fall effect. And the plasma levels and IOP kind of match each other, right? It's very interesting. But here's the one that was most important to me, because for the longest time, as a systemic drug, and one of the most heavily used drugs, my big concern was nocturnal hypotension. And all of the glaucoma patients I have who are the natural candidates for this drug are there with the intention of using it, over the course of a day. And I didn't want a more moderate to advanced glaucoma patient end up having hypotension while we know the IOP is going up as the evening goes on. This study showed that that is actually a fallacy. They had no notable change in the diastolic pressure, a couple of millimeters of mercury, nothing big. This is a well-done study by 3 really good people. I'm much more comfortable now having my patients use this as an oral drug if they choose to manage their glaucoma. And I'll have them use it just at night because we can get good IOP lowering with very little systemic effect while typically the IOP would go up. So with that said, I'm going to finish up. We have reached the witching hour. It is exactly 2:40. And Jen, I'm going to have you come back in and we can take some questions here, which would be awesome.
I'm coming. My computer's running slow. Okay. Okay. Let's see I'm working on it. I'm here. So I will start talking while my video slowly.
Well, while you're doing that, let me make a comment that I neglected to insert into that herpes simplex analysis. When you put that yellow dye on the eye or when you put the lissamine on, it's obvious we're going to look at the cornea. There are a reasonable number of patients who will show other than corneal disease, which is conjunctival dendrites. Conjunctival dendrites don't look at all like corneal dendrites. They're not that arboritic type of change. They're more little oval lesions in the conjunctiva. That's herpes. All right. It's not the classic herpes, but it is conjunctival herpes, and it's just as important to treat the patient as a result of that. So I forgot to mention that. Okay.
Thank you. I'm here. I don't know what happened to my computer. It decided to, of course, at the moment I'm trying to turn my camera on, that needs to be slow. So thank you. That was amazing, Jim. That was a fantastic, huge summary of medications and cases. And you see some amazing, crazy things. I'm always thankful that you're my neighbor and I can send you some of those crazy things that I don't know what to do.
Well, so one of those crazies might have been yours, Jen. I don't remember.
There was one. There was definitely one.
There probably was. There probably was.
Thank you for taking good care of that person because it was definitely not in my wheelhouse. So I can attest that you take very good care of them. And so as we're talking, make sure we do have some time for questions. So I know there were a lot of questions, but please, if you have a question that you didn't enter, now's the time. This is a great few minutes we have. We will be putting a QR code up, so wait for that. And then before we finish, don't leave. I do have the two raffle winners for our Starbucks gift cards that I'll announce when I put the QR code up. So be ready for that.
Let me, you know what, Jen, I'm just going to grab a couple of these. I have them up here. Do you mind if I? Okay, we'll go number 1. Can herpes simplex manifest as conjunctivitis with no involvement? Absolutely, doctor. And I would treat it appropriately, depending on level of involvement. If there's no corneal involvement, I'm not sure you have to do a whole lot because it is relatively self-limiting. But if the patient's symptomatic, I think that's reasonable to do. Do you still suspect herpes if symptoms are bilateral? Generally not. I think that's a really good question, whoever asked it. Thank you for that. That's very clarifying. I tell my residents and students that herpes is almost always bilateral, except in 2 conditions. This is a corneal fellowship board question to get their board passage. First is immunocompromised patients, cancer, occult disease, those types of things. The second, which is one that's really interesting because it's on the rise and it's the #1 new allergy disease in America, is atopic disease. If you have really bad atopy, your immune system is so occupied dealing with the atopy, you've got nothing left to handle the virus. You can have a bilateral simultaneous herpes infection. So yes, great question. And you can now take your cornea board, so you're good to go. Any risks with post-kidney transplant patients? No, I think that's fine. That's also a very good question. And there are many patients with transplants. My son actually is one of the major officers of DaVita, the largest dialysis company in the country. So I'm actually sitting in his house as he works out of Charlotte, but he runs the entire South and Midwest. So we'd have that discussion. I've had discussion with his experts, and they're happy with that so long as their numbers are good. If a betadine hypochlorous wash with viral conjunctivitis, you know what? That's a really interesting question. The adenoviruses do not have the same response. Well, they have a much more sensitive response to this. Viral disease like herpes and herpes simplex and zoster just don't show that response. And I do like the idea of the hypochlorous. I think that's actually quite valuable. Yeah, look, if you don't think it's herpes and you want to know if it's herpes, do a corneal sensitivity test. Just take a cotton swab and Oh gosh, I'm getting tons of questions here. Take a cotton swab and tease it out and touch the herpetic eye first. Just have the patient open the eye, touch the eye, ask them if they have sensation, and then, excuse me, touch the good eye first and then touch the herpetic eye second, and ask them if there's a difference. And I think you probably will. So if you see that, then that's absolutely. Would you consider an amniotic membrane for patient with corneal maladies? Oh, absolutely. That's, today that's a given. 5 years ago, maybe not so much, but today the amniotic membrane is a major part of our armamentarium. Thought of this question when you mentioned the episcleritis in one of the cases. Whoops, people are typing in so fast, I'm losing my questions. There we go. Textbook method for differentiating episcleritis from sclerosis. Do you always use the technique? I will, sometimes I do. I think it's a really good question. I've seen so many of them, I've become pretty comfortable that I know what I'm looking at, and I'm pretty comfortable I can do that. So I go ahead and do that. But if you're concerned, I think that technique is actually quite valid. Do they still call herpes in a 13-year-old chicken pox? That's an interesting question. If they've been vaccinated, it's not chicken pox. It's just chicken pox, but it's herpes zoster. So yeah, you can label it zoster. When you treat scleritis, do you have the patient use PPIs with a high dose ibuprofen? I think the use of proton pump inhibitors are absolutely essential. I would tell you that's a very nice additive to the lecture. I use that when I have chronic doxycycline. I even tried it on myself. I wasn't so successful. But the PPI is actually excellent for patients you're putting on oral drugs. So please feel free to do that. You do oral Vanco? No, not oral Vanco, only topical Vanco. Oral Vanco is really, really dangerous drug for ocular use. Oral doxy for plus, as I said earlier, I'll define my use of oral doxy in the following way. Anybody that you think has a sight-threatening lesion should be on oral doxycycline and vitamin C, in addition to whatever antibiotics. I've noticed that I've been unable to prescribe Metin formulation here at the VA. I wonder if there's a state change. You know what? I think it's probably more of an access issue, Glenn. We had a little moment when we couldn't get it either. So I think it's mostly access. I don't think it has anything to do with legislative issues in optometry. But we did have a moment when that was a problem, and that was good. What dosage is used to treat Dupixent eczema? Typically, what I'm using is I'll use loteprednol to start topically 4 times a day. If that's not enough, I'll bump them up to steroids, okay? And please share the QR code. So we are good to go. Thanks for the invitation. Yeah, go ahead. Yeah.
I have a couple more from, let's see, from the chat. Have you seen doxycycline used to treat hordeolum if they have concurrent meibomianitis? Or would you say?
I think if they have meibomian disease, I think that's a very good use of doxy. I would not use doxy in the absence of notable meibomian disease. I don't think it's very effective, to be honest. Omega-3 fatty acids are a much better long-term. Reesterified fatty acids are a much better long-term treatment.
And then do you use Besavins with Zergan in cases suspicious of bacterial versus herpes?
You know what? All of the 4th-generation agents are useful for gram-negative. Besavins has a slightly better profile on gram-positive. It's just kind of hard to get right now. Insurance companies don't want to pay. They want generic. So if you can get it, awesome. We quit prescribing it because we had probably 25 consecutive denials. And I don't have a full-time person to do my PAs. So I had to kind of balance it. But I do think moxifloxacin generic is a very good drug because it's also not preserved. And it takes away that toxicity from the preservative when you're using it at high dose.